Good morning, everyone. My name is Justin Peralta. I'm one of the co-presidents for the class of 2024, and I'm just here to introduce everybody to the event. Um, on behalf of class council and so many turtles who put in months of work to Family and Friends Day, we really appreciate you guys all being here. We should be keeping according to schedule the itinerary that was posted, but of course, with technical difficulties and an online event, we may run a little bit off course, but please be patient with us. And again, we're really excited that y'all are here and we're ready to have an awesome day. Without further ado, I'll be introducing Annie.
We would just like to acknowledge the land on which the University of Guelph campuses are situated and the Indigenous ancestors who have inhabited these lands for centuries. Our campuses are located on the lands of the Dish with One Spoon Wampum, and we offer our respect to the Mississaugas of the Credit, the Delaware Nation, the Six Nations of the Grand River, and the diverse communities of the First Nations, Inuit, and Métis people who reside on these lands. We also recognize that our educational and research establishments occur on Indigenous lands across Turtle Island and Mother Earth, and we endeavor to ensure that our activities honor and respect Indigenous people and their lands. Up first to talk to us today is Dr. Joanne Hewson. Dr. Hewson is the Associate Dean, Students and Academic for the Ontario Veterinary College. Dr. Hewson graduated from the OVC and then completed an internship and staff veterinary position at the Atlantic Veterinary College in Prince Edward Island, before returning to OVC to complete her residency training and PhD program. Dr. Hewson is a board-certified internal medicine specialist. In her role as an associate dean, she's responsible for the DVM curriculum and student experience. And in this pandemic era, Dr. Hewson has led and supported the faculty and staff through multiple iterations of instructional redevelopment to ensure that our DVM students continue to safely receive the full curriculum in creative ways that support their learning and skills development. So from here, I will pass it along to Dr. Hewson.
Thank you very much for that, Annie. Good morning, everyone. While we're not able to meet each other in person today, to shake hands, lock eyes, and smile together as we celebrate this very exciting event for the Topaz Turtles, there is still much to be said in being able to connect virtually, to overcome the barriers of distance and travel, and still grow our relationship together in a meaningful way, as being the community that supports each turtle. As Annie said, I'm Joanne Hewson, the Associate Dean, Students and Academic, and I welcome the chance to share in today with you. We've just had our territorial acknowledgement, and I'd like to express thanks to Annie for her words today, as we all take pause to check in on ourselves that we do not become complacent in our day-to-day lives, that we constantly remember we can all contribute to making the mistakes of our yesterdays be the lessons of today that shape the improvements in society for our tomorrows. As a college, the OVC stands on the doorstep of making such significant change. We are currently embarking on a consultative process to advance our vision of equity, diversity, and inclusion as a college. We are also just concluding the interview process with some truly top-notch candidates to help lead our Kim and Stu Lang Community Healthcare Partnership Program, which will build our students' competencies in cultural awareness and humility, giving them the tools to improve access to veterinary care for all members of society. I'm encouraged to know we are moving the needle in a meaningful way. It excites me to know that we, as a college, have some really strong opportunities sitting before us in the here and now that will allow us all to give back to our communities. And it excites me to know that we, and importantly our graduates, our Topaz Turtles among them, will be better positioned to respond to the call to action for reconciliation, to better enable racialized or marginalized groups, to make the world, our world that we all share, a better place. As we get started on today's event, I'd like to give the background. Family and Friends Day began in 1997, meaning, as a graduate of the OVC 1996 Links class, I sadly missed out on this amazing event. Our goals for Family and Friends Day are twofold: to connect, or reconnect if you were here virtually with us back in September, with the literally hundreds of supporting cast members behind our student veterinarians. And secondly, we want all of you to know more about how your student veterinarian spends so much of their time these days, to get an idea of what they do in the DVM program, a little bit about where they do it, plus who their friends are, and in short, what a school day is like in the life of an OVC 2024 topaz turtle. As you're probably catching on at this point, there is always a large emphasis placed on class identity, with the class color and mascot representing a new community that your student veterinarian connects with at their very core. Today, you'll have an opportunity to share in the experience of being a topaz turtle. You will experience several of their current course professors and hear about some of the topics and skills they are learning in their first year on the journey of the program. I know you're going to have a wonderful time today. And as I close, I want to extend my sincere thanks to all of the people who have worked so hard in putting this whole day together. In particular, the entire OVC 2024 Family and Friends Day Committee, who were and continue to be today so well supported by Elizabeth Lowinger, our Manager of Student Affairs, Scott Mokia, who assisted with creating this meeting platform and advised on all the digital logistics, of which there were many, Amy Tremaine, who assisted with acquisition of sponsorship, the various instructors who are here today to share their world with us, and Kevin Hogg, our event producer, who is madly working hard behind the scenes today to keep it all running smoothly. I know our topaz turtles are especially grateful to you all. Family, friends, mentors, and all loved ones, even the furry ones in the household that may be joining us today too as a first for Family and Friends Day, I look forward to spending today with you. Welcome and thank you.
Next up to speak with us today is Dr. Jeff Wichtel. He has pre-recorded a video that we will be sharing with you to help introduce Family and Friends Day. Dr. Wichtel has been the Dean of the Ontario Veterinary College since 2015 and has recently been reappointed for another 5-year term. He is a farm animal veterinarian and he has taught at Iowa State University, North Carolina State University, Massey University, and the University of Prince Edward Island. Dr. Wichtel is passionate about veterinary medicine and One Health and the roles that they play in improving the health of people, animals, and the planet. The Wichtel family is also perhaps unique in the fact that Jeff, his wife Maureen, and their daughters Jocelyn and Nicola are all practicing veterinarians. So now I will pass it over to Dr. Wichtel.
Welcome, friends and family of the OVC class of 2024, the Topaz Turtles. I'm Jeff Wichtel, and it's my pleasure to welcome you to OVC and the University of Guelph. Turtles, you and your family have no doubt shared this dream of you entering veterinary school for so many years, and now you have a good part of the first year behind you. We congratulate you, and also wish to acknowledge your families, mentors, and supporters that have helped you along the way. Of course, I want to acknowledge all those who have helped make today happen. We all know how talented our students are, but perhaps you did not realize just how good they are at event planning and public engagement. Friends and Family Day is largely a student-run event, as are many of our events throughout the year, such as Discover Vet School and College Royal. I'm always impressed with our students and their aptitude for planning and running events, which help to engage family, friends, and our broader public. Of course, there are many staff and faculty who assist and volunteer their time, and I thank them also. Public engagement is so important to us. While our earliest impression of a veterinarian was probably based on our family or farm vet who cared for our own animals, you'll now realize the many doors that a DVM degree can open. Veterinary medicine is without doubt the most interdisciplinary of professions. We recognize we need to do a better job of showing the many ways in which the craft of a veterinarian benefits society. Improving animal welfare, protecting our environment and biodiversity, tackling emerging diseases such as the novel coronavirus, seeking ways to provide care to animals that do not normally have access to care, these are all contributions that veterinarians are making every day. Students, this profession will provide you with countless opportunities to contribute to the health of animals, humans, and the environment. Today is your opportunity to share with your family and friends the full breadth of the profession. Friends and family, you can rest assured that your topaz turtle made a good choice. The bonds between humans and animals have never been stronger, and veterinarians have never been in greater demand than they are now. Have a wonderful day, and friends and family, never hesitate to contact me if you have any questions about our program or our profession. Thanks.
Up next to speak with us virtually today is Dr. Paul Woods. Dr. Woods is president of the Ontario Veterinary College Alumni Association. He is also a professor of oncology in the Department of Clinical Studies at the OVC and was founding co-director of the University of Guelph Institute for Comparative Cancer Investigation. Dr. Woods is a graduate from the OVC himself, and upon graduating, he practiced in Owen Sound, Ontario, and then continued to complete a residency in small animal internal medicine and a master in veterinary science at the University of Wisconsin-Madison. Dr. Woods also completed a medical oncology fellowship at Colorado State University and was formerly on the faculty at Oklahoma State University. Currently, Dr. Woods is board certified with the American College of Veterinary Internal Medicine in both internal medicine and oncology, and his research interests include therapeutic and diagnostic agents and techniques in clinical trials with veterinary cancer patients. So from here, I will pass it along to Dr. Woods.
Welcome, student veterinarians of the OVC class of 2024, the Topaz Turtles, and your family and friends. I'm Paul Woods, member of the OVC class of 1985, the Polar Bears, and president of the Ontario Veterinary College Alumni Association, and a medical oncologist here at OVC. The OVC Alumni Association supports alumni and students by developing and running programs and activities to enrich your continuing education and expand your network within the profession. Throughout your time at OVC, as well as once you graduate, the OVC Alumni Association will be there to help you. Your class has a representative on our board. We support continuing education symposiums, which are great opportunities for learning more about veterinary medicine. Last fall, we had virtual lectures on emergency medicine. We have receptions and networking nights, at present in virtual form at conferences across North America, which are good ways to meet other alumni, expand your professional network, and reconnect with colleagues. Next month, we will have a virtual meeting in place of the postponed Ontario Veterinary Medical Association OVMA conference. We also want to bring students and alumni together just to have fun, like at our annual OVC hockey tournament, when we can get back into the arena and back on the ice. The Alumni Association also helps to support future growth and development of OVC through scholarships and alumni class projects and fundraising campaigns. We welcome you to the OVC Alumni Association and welcome you to join our events here at OVC and outside the college. Again, welcome today to you, your family, and friends, and have a great Family and Friends Day.
Right side down, I can be you. To the sternum and around. Elevator up. And all the way around. So it goes like this. Right side down, I can be you. To the sternum and around. Elevator up. And all the way around. And the moment you call it the right dorsal colon, the whole arrangement fails. Any ideas what I was thinking about?
Good morning, everyone. I'm Ikshaya, and I'm going to be reintroducing Dr. Houston this morning, but this time as one of our amazing professors. You met Dr. Houston earlier today in her role as Associate Dean, Students and Academic for the Ontario Veterinary College. But she's also a faculty member in the Department of Clinical Studies, performing roles in both research and teaching. While Dr. Houston's earlier research focus was on respiratory disorders, with a strong focus on bovine pneumonia, she has expanded her research in more recent days to also include the scholarship of teaching and learning within the veterinary program. Dr. Houston teaches in the clinical medicine courses of phases 1 through 3, and in that role, she teaches all DVM students clinical skills in safe handling and examination of large animal species, in particular horses, cows, and sheep, as well as the art of clinical problem solving when presented with sick patients. Today, she's going to share with all of you some of those skills that we learn in our Phase 1 clinical medicine course.
Perfect, thank you. Okay, so I get to have some more time with you, which is amazing. I love being able to connect with the family and friends of all of our veterinary students and share a little bit about what we get up to. So while I'm dressed in fancy attire today, this is not how your topaz turtles are used to seeing me. More consistently, they are used to seeing me in my coveralls over in the barn, where we do a lot of practice together working with the horses and the cows and the sheep. So they asked me to share a little bit today about some of that they're experiencing so that you can also gain some insights into being a veterinarian. At the very, very last second, I added this QR code over on this side, this round circle. I don't know if it's going to work, but give it a try. See if you can scan it. It will take you directly to the link for my videos and my audio, just in case they don't work today. So this is the first time I've done this way, but this is a year of firsts, so we're going to give it a go. So I mentioned I teach a lot to the students in our clinical medicine courses, and to give you the context of that, we have 3 consecutive clinical medicine courses, 1 in each of years 1, 2, and 3 of the program. And the essence of these courses is helping our student veterinarians learn how to be a veterinarian. So not all the knowledge about the various diseases necessarily, but how to get there and figure them out. So we spend a lot of time learning these in hands-on ways and by practicing through cases. This picture shows us over in the barn with our cows, but today we're actually going to focus in on the other part of our barn with the horses. In terms of what we learn in clinical medicine, the required skill set that we're aiming to achieve by the end of the 3 years is that for the various domestic species that our student veterinarians work with, they will know what information is important to gather about that particular species as they take the patient history and evaluate the animal. They, of course, need to be able to safely and humanely handle and restrain the animal in order to do an examination to get all the information they need. And as well, when they are handling them and restraining them, that physical exam has to be done in an appropriate way to pick up all the finer details about that particular species and animal. Once we've found whatever problems are existing in the animal, then we need to know what tests to use. and how to interpret the results of those tests to figure out which of our various hypotheses is correct, and then to know what treatments to give and how to give them. So it's quite a lot that we cover in the clinical medicine courses. And, you know, I mentioned it's over a 3-year trajectory, but realistically, we knock off the first 3 in the first year. So your student veterinarians in the topaz turtle class are working on these 3. They're learning what's important for each species, what's the same and what's different. They're learning how to safely and humanely handle a variety of species. Many students came into this year not having handled a horse or a cow or sheep before. So it's been a very steep learning curve. And I was working with half the class just this week in the barn and assessing them on their skills in this regard. And I just want you all to know, as the family and friends, that they've got this. They have practiced so hard and are really doing a super job and are very able to do this at this stage. And then similarly, they learn the physical exam of normal animals in this year. So again, we're practicing that in the barn right now and working our way through testing them on that. So lots goes on in ClinMed, which I guess is probably why they wanted me to share with you today. In terms of today's case, we're now moved over into the horse wing of our barn. So this is looking down the aisle of the barn. And we are going to turn our attention to Miss Mary. So Mary is currently having her dinner. So we're going to interrupt her dinner to do a physical exam on her. And I'm going to take you through some of the steps, not all of it, because I only have a short window, and normally it takes me about an hour and a half to teach this to the class. So we'll just capture some of the highlights. All right, this is where I get nervous to see if everything's going to work. So the first thing we're going to do before we go into her stall is we're going to take her respiratory rate without disturbing her, because we want to make sure that you know, we get a representative respiratory rate with her at rest before she gets excited that we're there to see her and starts sniffing us, and her respiratory rate alters as a result. So I'm going to be playing the video for you momentarily, but I just want to let you know that what you're going to be doing is you're going to be taking the respiratory rate on this horse. And generally what we do is we count the number of breaths over, say, 15 seconds, and then depending what number we got in 15 seconds, we then multiply it by 4 to get the respiratory rate over a minute. So she's going to be breathing in and out, and you're going to be counting that. And just as a hint, you might want to watch the side of her belly where you can see the contrast between her brown hair coat and the wall, because it'll be easiest to see her going in and out as she takes each breath if you look there. So I'm going to start it, and then I'm going to be counting to 15 while you're counting how many breaths she takes, and then we'll compare notes. So here we go. I hope it works. Okay, so that's 15 seconds. And we don't have the chat feature up and running, so I was going to get you to type in how many breaths you counted there. I was counting seconds, but I think I saw 3 breaths go by as I was counting that. So 3 breaths in 15 seconds. So you're looking at 12 breaths in a minute. And so that's basically how we're collecting the respiratory rate. And as I mentioned before, really critical that we do that while she's at rest and not being disturbed. So the normal respiratory rate for horses at rest is 8 to 12 breaths per minute. And so as a veterinarian, it's important that you know what normal is, so that when you do things like take the respiratory rate, you can identify when something falls outside the normal range and is abnormal. So good going, Mary. You have a normal respiratory rate. That's a good start. Now it's time for us to get in the stall and actually handle Mary to do our physical exam. So the first thing we need to do when we go in there is we need to be able to take a hold of her so we can work with her safely. I always check the volume to make sure it's turned down, because there were students practicing in the background when I took these videos, and you can hear them chattering away. Okay, so we're in the stall with Mary and we're going to put a lead rope on her, and this is one of those restraint skills that I talked about that your student veterinarians have learned this year. So they've learned how to safely go into the stall, handle the horse, put a lead rope on her, and then be able to handle her while they're doing their physical exam. And as I mentioned to you earlier, Mary was in the middle of her dinner when I took these videos, so it's very food oriented and goes right back to eating as we're doing the rest of our work. So we do a bunch of things starting at the head on the physical exam. There's a lot that we do. I'm just going to cover a few highlights. For instance, we might palpate the horse's pulse. So you can see up here that my hand's in the position to palpate the pulse. And what we're actually looking for is not the blue vessel, that's a vein, but right beside it, the O, that's an artery, the facial artery. So we're trying to get our fingers onto that artery so that we can feel every time the heart pumps blood through the arteries, we feel it as a pulse. So that's one of the things that we would do on the head. We also do careful evaluation of ears, eyes, nose, and mouth. So this is an example of some of the things we do on the eyes. For instance, looking at the pink tissue, the conjunctiva, to see if it's inflamed. You know, when people get pink eye, that's inflammation of the conjunctiva or conjunctivitis. So we check that. Similarly, we look at the whites of the eyes to see whether there's any issues with liver function or severe infection that might cause the vessels on the sclera to be very angry and injected looking. So we teach the students how to actually handle the eye and the eyelids to be able to do that. Now, unlike you and I, horses have a third eyelid, meaning not only do they blink up and down with their eyelids, but they also have a third curtain that sweeps across the eye each time they blink. So that's called the third eyelid. And we need to be able to examine that as well, because sometimes it might have a tumor on it, or it might have like a burr from out in the field underneath it. So we teach the students how to actually manipulate the eye to be able to see the third eyelid as well. Here we are looking in her mouth. Okay, full disclosure, this is not Mary. This is a different picture from a different horse. I have a few of those in here. So we're looking in the mouth at a variety of things, their teeth, their gums. One of the things we do in the mouth is we do their capillary refill time, which assesses the blood's perfusion into the tissues. So how well is the heart delivering blood to the tissues is what we're checking. So right over the chompers here, we put our thumb onto the gums and we press for 1 second, and that makes the blood sort of move out of the way so it looks white, and then we count how long it takes to come back to a nice pink color. That's the capillary refill time, and it reflects the perfusion of that tissue. So normal capillary refill time would be less than 2 seconds. Ask your student veterinarian, they know that. So finally in the mouth, we're going to actually go and put our hand in the mouth to check how the tongue tone is, to make sure the horse has good neurological function and can move its tongue around. So we don't want to get bitten while we're doing this, of course. So knowing the horse anatomy is very important at this step, of course. And in particular, we want to know where the diastema is, which you can see is this space with no teeth. So we check where that diastema is, make sure there are no teeth there, and then we gently slide our hand in from the side, staying away from all the teeth so that we can touch the tongue and make sure the horse is able to move it appropriately. So this is me just checking the tongue tone of the horse after having checked the diastema for no teeth, so I don't get bitten. And your student veterinarians do this as well. Finally, on the head, we check their ears. They're rather tall, so we have to kind of push the ear down to have a look in it. But as with all of our patients, you know, it's important to do a thorough examination of all aspects of the animal. So next we would move down the neck and check for any lumps or bumps and check that their veins are all in good shape, and then move down to the shoulder and the forelimb. And we would do a thorough palpation down this leg. So we would have, you know, we would spend time touching each of the joints that are here. We would pick up this foot and check underneath to make sure that everything is okay. And so in order to do that, your student veterinarian really needs to know the anatomy underneath there so that they know what they're palpating as they go. So concurrent with clinical medicine course, they are also taking an anatomy course, as I'm sure you've heard. And they rely heavily on the knowledge from that course as they work to do their physical exams. Once the forelimb is done, we're going to pull out our stethoscopes and actually do some auscultation. And so again, you need to know where to put your stethoscope in order to hear the things you're trying to assess. So let's start with the heart. And so again, we need to know where it is. And I'm just going to orient you that the horse's head is up to the left here. Her bum's off to the right-hand side of the picture. And we're looking at her forelimbs right now and her shoulder, basically, shoulder and chest. So underneath her shoulder and her chest lies her heart and lungs. Again, same orientation. Horse's head is off to the left. The bum is off to the right. And we've just got her chest here. And these are the bones of her shoulder that you can see. And I've pointed out in particular one of them, the bony end of one bone, which we call the elbow. So that is a part of the horse that you can palpate, and you can actually feel exactly where my arrow is pointing. Right above it in the picture, you can see lies the heart, which is the darker red structure. So if you can palpate and find that point of the elbow and go above it, you will be at the heart with your stethoscope. So in ClinMed, we learn to tuck our stethoscope in under their armpit and get up 1 inch above and 1 inch forward from the top of that point of the elbow. And that's the loudest spot to hear the heart. This is the one recording that I'm not entirely confident you will hear well. We'll see how it goes. I'm on my third recording stethoscope, but I still haven't found one that can do this well. All right, let's give this a go. I have 2 different ways I can play it. I'm going to play it, and then if they text me in the meeting chat that it's not loud enough, I'll try the other way. We'll see how it goes. So is that audible at all, my fair chat friends? Oh, it is. Okay. So this recording is actually Mary's heart. And as I mentioned before, when we go to take a rate of something, we count it over 15 seconds and then we multiply by 4. So I'm going to restart this recording, and you're going to count the number of heartbeats you hear while I tell you when to start and stop. Get back to the beginning. Bear with me. And then we'll multiply by 4 and see how we did. Are you ready? Get your counting ears on. Okay, start. Stop. So depending on your counting, you may have gotten 9 or 10, depending how fast you started. And that again was in 15 seconds. And so we're going to multiply that by 4, and that will give us our heart rate. So 36. Normal heart rate for a horse at rest is 28 to 40 beats per minute. So again, Mary sits in the normal range, which is great. And also when we're listening, we want to make sure that the rhythm is nice and consistent. So you could pretty much tap your foot to the rhythm and you would know when each beat is going to come, which is true for Mary. So far she's checking out quite well. Now we're going to keep our stethoscope on and move up to her lungs. And as you saw from the earlier picture, we've got the heart right above the point of the elbow, and all surrounding it in the lighter pink color here are the lungs. So knowing where the lungs sit in the body is important as you go to place your stethoscope on the horse. And essentially what we're going to demonstrate is that you map out your triangle where the lungs sit, and then you specifically use your stethoscope all over that field to thoroughly listen to the lungs to make sure that they're healthy. So this is a video of me mapping out the lung field. And if you end up needing a password for any of these links, it's just FFD, like Family and Friends Day in capitals, 2021. And we can put that at the end for you as well. Okay, so FFD 2021. Here we go. So we're going to draw our big triangle on Mary, starting from her elbow, going up, and then going across to the point of her hip, and down to the elbow again to make the great big triangle. The lungs don't go all the way back, so we're going to cut off that triangle by going to the second last intercostal space. So here I am palpating the ribs to find that second last intercostal space to chop it off. And then you want to divide that into 3 zones so that you make sure you put your stethoscope in the middle of each zone to hear the lung sounds. When you put your stethoscope on, it's important that you correlate what you're hearing with actual breathing, because you hear a lot of other stuff too. Like you hear the stethoscope brush against the hair every time she wiggles. She actually secretly was also stealing a bunch of mouthfuls of hay during this, so I would hear her chewing. So as a veterinary student, part of the skill development is learning to watch the breathing movement and mentally eliminate all those other background sounds in your stethoscope, so you only pay attention to the ones that exactly match her breathing in and out, and those are her respiratory sounds. And your student veterinarians can attest that's quite a tricky business. There seems to be some chatter about the videos not running. Are we doing okay there? It's working okay. All right. So as you see, it takes quite a while to do lung auscultation because you have to listen to a full breath in and a full breath out every time you're at a new spot before you move on to the next spot. And you're doing like 5, 6, sometimes 7 spots, depending how big your animal is. So respiratory or lung auscultation can take quite a bit of time, but it's important you do it thoroughly as you go. All right. Similarly, while we still have our stethoscope on, we're going to listen to some intestinal sounds. So we're on the left. We need to know what anatomy is underneath there so that we know when we're hearing these sounds what structures we're listening to. And in terms of the left side of the horse, you just hear general gurgling and not really anything beyond that. There I am, FFD 2021 again. And we will oh, this one's stalling out on me. Might have to can this one. Oh, here we go. So we've got just a bunch of background gurgling happening. Occasionally you'll hear her take a breath too. So just gurgling along. And I imagine for those student veterinarians in the room right now, you're saying, I don't remember hearing quite so much gurgling. Don't forget, Mary's in the middle of eating her dinner right now, so her GI tract is really switched on and doing its thing. So this is actually increased intestinal motility compared to what you might be used to. Different horse, but I did want to get you the chance to hear the right side because it's a little different. So on the right side, you actually have one structure who doesn't just consistently gurgle, it's the cecum. And so the ileum empties into the cecum through the ileocecal valve, and that happens periodically, and it sounds like a bit of a toilet flush or a thunder roll. So let's see if we can listen to that and see how that goes. Wait for it. There's the ileocecal flush. So you have just background gurgling for a while, and then every 20 to 30 seconds you get that sort of flushing sound. That's the ileum dumping into the cecum. So we check for that to make sure we can hear that as we're assessing the horse. And then There's a bunch of other stuff we do. We're going to fully palpate the hind limb as well and take their temperature. We also need to make sure we're checking underneath the horse, and that can be a bit dodgy at times. They're not all super fans of you reaching underneath, so oftentimes it's more of a visualization to make sure there's not a problem, and you only put your hands under and do a feel if there's a problem that you need to investigate further. So, whoop, sorry. So this is just us sneaking a quick peek underneath at her udder to make sure that all is good underneath there. I don't see any problems, so we're not going to reach under and do any palpating in this particular instance. So that's a bit of a whirlwind tour of the physical exam, and it's not comprehensive by any means, but it gives you a bit of a chance to see some of the skills that your student veterinarians are learning in animal restraint and handling and doing physical exams on normal. Next year, they're going to move on to figuring out abnormal. So we're going to take the focus of common presenting complaints and how to figure them out. So I'm going to now hand it over to you, but before I go, a bit of an echo, just to let you know, the link to the folder works till tomorrow. So, you get a quick window of time. If you want to download them, you're welcome to download them and use them. I don't mind sharing that, but I will close the link tomorrow so that I'm able to move it around and not break that for you. Okay, there we go. If we didn't get the link to you successfully, your topaz turtles will take care of that with me right afterwards. Enjoy the rest of the day.
Down by Green River, where we used to go. By Green River, away she goes. Until one day, another lover comes my way. Till then I'll go the Green River all alone.
Hi everyone, my name's Olivia and I'm here to introduce you to Dr. Peter Conlon, who's here with us live today to talk about the importance of communication in veterinary medicine. Dr. Conlon is a professor in the Department of Biomedical Sciences at OVC. From 1995 to 2018, he was assistant, then associate dean of students for the college. He's been the coordinator of the Art of Veterinary Medicine 1 course since its inception in 2000. And has always greatly enjoyed his interactions with student veterinarians.
How vets communicate, because you might say, well, don't they communicate like everyone else communicates? And certainly in our personal lives and in many situations we do, but in our professional lives and in practice situations, veterinarians communicate with a whole range of skills that are not typically known by the general public, even though we all use these skills in one way or another, probably without knowing it at times in our day-to-day interactions. So perhaps you'll see how some of them resonate with you in your day-to-day conversations. So why teach and learn communication in veterinary medicine? Interestingly, communication is the most commonly used veterinary skill and is most frequently cited as necessary for success in practice. And in fact, the average veterinarian in practice will communicate with clients over 100,000 times in their career, which is far more than the number of surgeries they'll do or the number of diagnostic tests they'll do. So it's a very, very important skill to know. Tied to that, perceived, and it's not necessarily there is poor communication, but perceived poor communication is the most common reason that clients complain about veterinarians to licensing bodies. So that's an important fact to pay attention to and to see if we can do something about that. And finally, skills to communicate well can indeed be learned. It's not just an innate thing that we have. It is a learnable skill, and mastery of those skills takes time, experience, and practice. So what happens when communication is good? There's improved health outcomes. So diagnosis and treatment accuracy are improved because the client will have provided the most accurate information and complete information to the veterinarian, and that helps a lot. A lot of diagnostics is getting the history and understanding what's going on with the animal before they got to the clinic or before the veterinarian went to the farm, for example. Decision making, it's important that there's shared decision making between veterinarians and clients, and communication is critical to that. Adherence, and meaning once the veterinarian leaves the farm or the stable or the client leaves the clinic, it's all up to them to follow the veterinarian's guidance as to what should happen. And so that's important, that the client knows what they should do through good communication, and increase patient safety because the client is better informed, and hopefully fewer errors, that there's no confusion about what we mean, how many of these little pink pills Fluffy should get every day, for example. That should be absolutely clear. Improved business outcomes, client satisfaction is improved by good communication. And you might reflect on how you chose your veterinarian, your physician, your dentist, any other professionals you deal with. A lot of it is their bedside manner, for want of a better word, and a lot of that is their communication skills. Practice success, so happy clients, recommend other clients, and business will increase, and hopefully reduce risks and complaints. And in fact, the majority of the complaints about communication that are made to licensing bodies are resolved through some further discussion between the veterinarian and the client, mediated by the licensing body. you'll know that well-being of our students and of veterinarians is a critical piece of the mission of OVC, and being able to communicate well, being confident in their ability to communicate is improves students' well-being and reduces stress, so that they feel as confident as they can in the way that they communicate and what they're communicating. So how do we teach communication? We teach it through a series of lectures from myself and several guest lecturers. We teach it through tutorials, which are large groups or half the class at a time in kind of a lab setting where we practice together the skills of communication. And we also practice through what are called simulated client laboratories. And these happened in January. And these are usually pre-COVID face-to-face interactions. This almost looks shocking now to see people sitting in the same space without masks on and without social distancing. And this year we did it all online, which worked really well. We were really happy with how it went. But typically there is a student coach, so a classmate who's coaching the student, a veterinarian who is coaching the student as well, and a simulated client. Now, simulated clients are really valuable to our program. They are people who have joined us. They are very well trained to portray a character. So they're not really acting from a script. They have a backstory and they portray a character, and the students interview the simulated clients using the skills we're going to talk about in a few minutes. And they then get feedback from the simulated client, from the veterinary coach, and from their student coach colleague about how it went, areas that went well, areas for growth. So it's a really, really interesting process, and simulated clients, simulated patients, of course, are widely used in medical fields and other healthcare professions. So the main tool, the framework we use for communication is called the Calgary-Cambridge Guide. It came from University of Calgary and the University of Cambridge, first used in human medicine maybe 20, 25 years ago, and is widely used now. Overall, there's about 71 skills in the Calgary-Cambridge Guide, so it's very complex. Many of these will be mastered by our students by the time they graduate. This year, we focused on 11 of the skills, and I'm going to talk in a little more depth about some of those now. So there's 5 steps in the Calgary-Cambridge Guide that we talked about. The first one is initiating the consultation. And if you think perhaps to an appointment you've had with your veterinarian lately, see if you can think back and identify these components as to what happened in that interview. So the first of all, the skills of preparing before you go into the room or arrive on the farm, establishing rapport, identifying reasons for the consultation. The ones in bold, we're going to talk about a bit more in a minute. Second step, build a relationship. Their nonverbal behaviors are really important here. Reinforcing the rapport and involving the client in the process, so that it's not just a one-way street. Gathering information, exploring what's going on. What is the problem? What are the issues? Where's the client coming from? What are their thoughts on what's going on? Explaining and planning is the 4th step. So providing information that's useful and appropriate, and sharing decisions with the client at that point. What are we going to do about this situation? And finally, summarizing and closing, where there's planning and checking in with the client. So let's revisit some of these in a bit more detail. First of all, initiating the consultation, typically face-to-face this year, in some cases through telehealth. And so really a lot of adaptation of veterinarians having to make to deal with communication in a different way on a different platform than being able to see clients face-to-face. So establishing rapport with the client is one skill to help initiate the conversation properly. Greet the animal and the client appropriately and verify both their names. It's important that the animal is greeted as well as the client, because certainly from the client's point of view, they're a family member, if it's small animals, and they're just as important as the client themselves in being involved. We talk about how to introduce themselves and their role. I'm Dr. So-and-so. I'm here today to do this. This is, of course, if they have never met the client before. Don't need to do that every time. And demonstrate respect for and interest in the client. So some, how's your day going? How was the trip in? How's the family doing? Would you like to be seated, or would you like to stay standing? Those sorts of really interpersonal skills that are so critical to getting the interview off to a good start. The second skill is identifying the reason for the consultation, and that might be that clearly it's a vaccine appointment, but also maybe there's some other things that the client would like to talk about. So ask a question. How are things going today? What would you like to talk about today? What's on your mind today? Just to open up the process. Listen attentively. We focus on the most important communication skill is listening, not actually talking. And the reason I put for longer than 15.2 seconds is because in one study, this is in 15.2 seconds on average, veterinarians interrupted the client who was responding to this first question, which is pretty darn short. Unfortunately, in another study, physicians were identified as interrupting after 12 seconds. So I hope you're a physician and you're a veterinarian. Don't interrupt as quickly as some of their colleagues do. After the client speaks, make sure that everything is covered. This is the opportunity to make sure everything is dealt with, and then negotiate an agenda. So we're here to vaccinate Fluffy. But based on what you've said, I'm also going to look in her ears very carefully because you said they were smelly. So, and does that work for you? And then the client will hopefully agree to that, and you're off to the races. Second step, building a relationship. And this is an absolutely critical piece. I like this little cartoon because it shows that the client and the veterinarian both bring pieces to the relationship, characterized by the bridge. And once that is built, trust is the outcome. And a trusting relationship between client and veterinarian is critical. And building a relationship is a lot through things we don't actually say. The actual words we say contribute little, in fact, to the communication, how we say them, and the way our body is behaving and what we're doing is absolutely a critical piece. So nonverbal behaviors include vocal cues, or what we call minimal encouragers, which are things like, oh, go on. So they're not sentences, they're just little sounds that we make to acknowledge sound. Also, not making sounds. Silence is an absolutely critical communication tool. We are, as a species, quite uncomfortable with silence sometimes, and so using it appropriately is very important. Body movements, as you can see in this these pictures, all of the ways people are standing, the way they're using their hands, they're really critical to get the message. And I think looking at these pictures, you get a lot about the emotion that these people are conveying. How we stand, where we stand, or do we sit, how close we are to the client. You may know people who are what in an episode of Seinfeld was called the close talker, somebody who stands in your personal bubble, not so much these days, but pre-COVID, and they are very close to you, so much so that it might cause you to be a little uncomfortable. Touch, do you reassure a client through touch? Sometimes appropriate, always important to make sure that the client, at the hug, a touch on the shoulder, whatever it is, that the client would be comfortable with that. Eye behavior. So this is not always just eye contact. It's where you look, when you look. Is the client looking away? Are they looking down? Rolling the eyes and exasperation, not something you want to do. And facial expressions, of course, are such an important part of the way we communicate with each other, and it's characterized by the range here. Right now, when we're talking to others and we're wearing face masks, it can be challenging, as I'm sure you know, in trying to figure out people's emotions. And so interesting looking at all these pictures, how the eyes are so important to communicate emotions. And so we need to pay really a lot of attention to them. The third step, gathering information. And one way, there's many ways to gather information, but one way we do this is asking the right questions. And we talk about 3 different kinds of questions. The first is open-ended. So this is asking this client to tell their story. So what's going on with this cow? When did this lameness show up in this horse? How do you think the problem is progressing? It opens the door very widely, and the client then can tell their story, what's their experience, what's their meaning. Closed-ended questions, which are typically yes, no, or short answer, clarify pieces. Can you tell me how much Fluffy's drinking? For example, and some to narrow down the information in this funnel shape down here. And then indirect statements are requesting more information or clearing up confusion. Tell me more about that. So again, eliciting information, but not a question. Or you seem worried about the cost, and that kind of opens the door for the client to say, yeah, it's a little pricey, or no, I'm okay, let's keep going. Explaining and planning, the fourth step. And there's a lot to explain, and when we break it down, we don't want it to be overwhelming for clients. And one technique we talk about with our students is chunking and checking. So providing a little piece of information, a chunk, and then checking in with the client. Am I saying that clearly? Or is there a better way for me to say it? So taking it on themselves for the responsibility of the clarity. So physical exam findings, diagnostic test results, what's the diagnosis? What are the risks? What are the options and risks for treatment? What's the prognosis? What are the recommendations? We like to use the phrase, in my medical opinion. This confirms where this is coming from, and the value and cost of recommendations. Talking about value is critical in veterinary medicine. Clients may focus only on the cost and see a number with a dollar sign in front of it, which may seem very large. And without the context of value, then it's quite reasonable that clients may think, boy, I just don't know why this is costing so much. So the value is absolutely key here. Finally, summarizing and closing, and we talk with the students that beginning and ending consultations are probably the most challenging pieces. So one skill to close is to forward plan. So what's going to happen next, and then check in with the client if everything's okay. So you may wonder why I put a rocket here. We talk about recapping or summarizing as kind of bundling everything up that's happened so far. So we've talked about this and this and this, and we've decided that we're going to put Fluffy on this diet. this amount, and we'll check back with you in a month. And then the rocket is the launching pad. So all of that summary then is the launching pad to where are we going next. So that's where clarifying the plan is, and and we'll expect this amount of weight loss over the next month. And so there's the plan. And then finally, a check to see if the client willingly agrees to the plan. And when they're home, when you've left the farm or the stable or the swine barn or whatever it is, are they actually going to be able to carry out what you would like them to do? Will they be able to be adherent to the plan? And this is really, really important because, of course, it's up to them from now on. So giving them the last opportunity to ask any other questions, and also to confirm, yes, I can do that, and I know that I can call the clinic if there's any concerns, and you encourage that to happen. And so to make sure communication keeps on going. And with that, I will thank you very much for your kind attention, and I hope you enjoy the rest of the day.
Hi folks, I hope you're really enjoying Family and Friends Day so far, and we really appreciate you being here to share in a bit of what we get to do at OVC. My name's Jackie Normando, and I'm from Uxbridge, Ontario. I'm one of those kids who grew up wanting to be a vet. I dreamed of driving around in a pickup truck, going to farms to take care of animals, and thank goodness I'm on the path to maybe do that. You may not have heard, but hockey is a big deal at OVC, and I'm so excited. My second dream as a child was to play for Team Canada, so needless to say, I'm happy that hockey has a big history at OVC. You might be surprised to find out that we actually had a lecture partly about hockey in the first week of classes. That's how important it is here. I'm going to steal some info from Dr. Hannah's lecture to give you some interesting hockey facts, and at the end I have a fun jersey quiz. I'm just going to start the presentation here. Lovely technology. Okay. So in 1922, OVC moved from Toronto to Guelph, and Principal McGilvray, there in the green circle, thought the students should have some things to do, one of them being ice hockey. He founded the school's hockey tournament in 1931, the Challenge Cup. That was 90 years ago. The Challenge Cup is the oldest veterinary hockey tournament in the world. That's older than television. The first practical video camera was created in 1933. It's older than antibiotics. The discovery of the first sulfonamide antibiotic was published in 1935. And it's older than CBC, which started broadcasting in 1936. For the first 45 years, the tournament involved a single men's team from each class. OVC hockey has always been part serious and part fun. For instance, the class of 1952 won the Challenge Cup every year they were at OVC, while the class of 1969 loved hockey but didn't win a single game. The first Women's Challenge Cup was created in 1978, and now we have a system where OVC hockey plays in the University of Guelph Intramural League, and we have 2 teams for each class. A co-ed team that competes for the Challenge Cup, which is more competitive, and also a women's team which competes in intramurals but is more for fun, and anyone who wants to learn to play hockey. So we have something for everyone, which is so great. There's also a student versus staff division. Now I have a question for you. Whose team won the Women's A Division of Challenge Cup in 1993? So you can see her in the yellow circle, and I have a hint. She spoke earlier this morning. You're right, Dr. Hewson. In 2008, inspired by the Stanley Cup, the National Hockey League's trophy, Dr. Hannah made a literal Challenge Cup. Now, I've never met Dr. Hannah, but that's pretty awesome dedication to OVC hockey right there. It took him 4 years to make it, and it was finished in 2012, in time for the 150-year anniversary. Now we have a real trophy to play for each year. Since it's been finished, some famous hockey folks have come to see it, including Ken Dryden and Don Cherry and Brian Williams. That's before he got into trouble. The first class to declare a team mascot was the OVC 82 Toros. My favorite, however, is in 1984, the OVC class of 1986, the Clams, won the women's tournament. I personally think that's the best name, and it shows that we Turtles have a legitimate chance of winning. So this is what the Challenge Cup looks like now, and it's going to be on display in the new Path of Bio building. This base that Dr. Hannah also created is going to have the names of the players from every team that's played in the Challenge Cup since 1931 inscribed on it, in time for the 100th tournament coming up in 9 years. So to end off, I wanted to play a little game to see what you know about current OVC hockey. Each class picks a mascot comprised of a color and an animal, but it's kind of tricky because it can't be too similar to the colors and animals of the other current years. I'm going to put up a picture of a hockey jersey logo from some upper year classes, and I want to see if you can guess the class it is and their mascot from the logo. Okay, here's your first one. Get ready. I'm going to give you 10 seconds to guess. All right, it is the class of 2023, the Opal Otters. Okay, I have another one coming up for you. Ready? Okay, you have another 10 seconds. This is the class of 2022, Jade Jackals. Those are some pretty fancy logos. Honestly, I'm very impressed with all of them. And here is our Topaz Turtles 2024 logo. We don't have our hockey jerseys yet, but we're raring to go, and we're really hoping that we can get going and play some hockey against the upper years and try out our skills against them. So thanks very much for listening. I hope you enjoyed some of these facts, and I hope you have a great rest of the day and enjoy the rest of your time at Family and Friends Day.
Hey everyone, it's Michael here. Today I'm going to share with you a rather curious story. It's the story of how an alumnus of the Ontario Veterinary College helped provide the inspiration for Winnie the Pooh. Now our story begins in 1911 when a gentleman by the name of Harry Colburn graduates from the Ontario Veterinary College. Now after Harry graduates, he feels a desire to serve king and country, so he goes off to enlist in the army as an army veterinarian. Fast forward about 3 years, and Harry finds himself in a place in northern Ontario called White River. And while he's up there, he comes across a hunter who has in his possession an orphan bear cub. So Harry does as any other person would, and he buys the bear cub for 20 bucks. He names her Winnipeg and calls her Winnie for short. Now it's 1914, so the First World War has just broken out in Europe, and Harry soon finds himself on a ship bound for England. And he actually decides to take Winnie all the way there with him. When he arrives in England, he decides to entrust Winnie to the care of the London Zoo, and throughout the war, he would return periodically to visit her. His original plan was to take Winnie back to Canada with him after the war had ended. But what Harry did not foresee was that Winnie would soon become a favorite of the citizens of London. And it's at this point in our story that we must introduce a young boy named Christopher Robin. A young Christopher Robin loves going to the zoo with his father. He loves seeing all the animals there, but above all of them, he loves Winnie. And his father, Alan Alexander Milne, being so moved by his son's fascination with the bear, decides to write an entire children's book based off of her. And so it came to pass that an orphan bear cub from northern Ontario, with the help of one of OVC's alumni, would become the inspiration for the children's character that we all know and love. Well, that's about it for this story. Have a great day, and I'll see you next time.
So hi everyone, I'm Catherine, and I'll be introducing Dr. Grant's pet nutrition lecture. Dr. Caitlin Grant is originally from Markham, Ontario, and completed her undergraduate degree in animal biology, earning a BSc at the University of Guelph. She then attended the Ontario Veterinary College and graduated with honors in 2014. After graduation, Dr. Grant became an associate veterinarian in a private mixed animal practice. Dr. Grant thoroughly enjoyed her time in practice, but made the decision to return to the OVC in 2017 and completed a nutrition residency through the European College of Veterinary and Comparative Nutrition. She then earned a Doctor of Veterinary Science degree in September of 2020. Dr. Grant has recently joined OVC faculty and holds the Nestle Purina Professorship in Companion Animal Nutrition and is excited to be involved with the nutrition curriculum for all 4 phases of the DVM program. She'll also be heavily involved with running the OVC Clinical Nutrition Service. If at any point you have questions, feel free to email them to vetmed@uaguelph.ca. And Dr. Grant's lecture today has been generously sponsored by Purina. So without further ado, I'd like to welcome Dr. Caitlin Grant.
Hi, everyone. Thank you for that introduction. I just want to make sure that everyone can hear me and see my slides before I get too far into this. All right, great. Thank you. Thank you very much for that introduction. I'm very, very happy to be presenting today. I remember the Family and Friends Day back from my own vet school days, and I think the class of 2024 has done a great job turning this into a virtual event, so they've done great. And so today I'm going to be doing a little mini lecture about nutrition, and I'm going to focus on doing a nutritional assessment and making a diet recommendation. So before we get too far, I just wanted to mention about nutrition and how it's important in every vet appointment that we do for every pet that we see. So WSAVA is the World Small Animal Veterinary Association, and they have deemed nutrition as the 5th vital assessment. So what does this mean? It means that at every visit, pets should have an assessment done, and that should include evaluating the cardiac function, listening to their lungs, taking their temperature, assessing for any pain, but also assessing for nutrition as well. And so what does that actually look like? And so this is a tool that I use for nutrition consults, and it is a risk factor checklist. So it gives us some risk factors that we should consider, and when we're evaluating the patient, we can then check off if any of these risk factors are present. So the first few here on the screen are related to the pet's life stage, activity level, environment, and these are considered optional risk factors. So if these are checked off, an extended nutritional evaluation could be warranted, but we could also just go on with our appointment if needed. When we get to the bottom of this list here, these risk factors are related more towards the pet's health, what their current diet is, if they're fed an unconventional diet, if they're receiving any medications, and then also points related to their physical exam findings. So if they're under or overweight, if there's any weight change that's not been explained, any new medical conditions that are being diagnosed. So these risk factors are all considered mandatory. So if we're checking off these factors, it's really good support for us continuing with our nutritional assessment and delving a little bit deeper. So what exactly is an extended evaluation, and what do we mean by that? So there's a few different things that we want to really spend some time focusing on. The first one is reviewing the pet's body condition and muscle condition scores, because this is going to give us a good sense of the pet's overall health, and again, whether they're under or overweight. So here I've got the body condition score chart that we use. There are several different scales that exist. I like this 1 to 9 score, and I use this handout all the time because it's got nice pictures to show us what each score looks like, but then there's also written descriptions to help us score each pet that we're assessing. And so we're not only looking at the pet, to see whether they've got a nice waist, to see if they have that nice tuck under their abdomen, but we're also putting our hands on the pets and feeling over areas like over their ribs to assess how much fat covering is there. Based on this assessment, we're then giving the pet a score from 1 to 9. For dogs, 4 or 5 out of 9 is considered ideal, 6 or 7 is overweight, and then an 8 or a 9 is obese, and then anything under a 4, so a 1, 2, or 3 is considered under ideal. This score system exists for cats as well, but I just showed you the dog one today. So after that, we're also going to want to collect a thorough diet history. And so what does this mean? So when we say diet history, we might think of, well, just what does the pet eat? But really, it's a little bit more involved with that. And if I was to ask a pet owner, what do you feed your pet? I might get a very short, simple answer. And so one thing that we try to do is ask more open-ended questions. So a recent publication from the University of Guelph found that if we ask a question like, tell me everything that Fido eats in a day from the time you wake up in the morning until the time you go to bed at night, that gives us a more representative answer of everything that that pet eats during the day. So that could include treats and snacks that are fed during the day, maybe any medication or any food that's used to give with medications, as opposed to just, oh, I feed the blue bag and I get 1 scoop twice a day. Some other tools that are helpful to get this information include a diet history form. So for our nutrition service at OVC, we have a 4 or 5 page diet history form, so it's quite lengthy. And this gets sent out to pet owners in advance so they can fill it out at home, write everything that their pet eats, any treats, any supplements. And then there's also questions that ask about who's responsible for feeding, whether there's any other pets in the house, the pet's attitude about food. So do they eat really quickly or do they leave food left over? And so the pet owners can fill that out in advance and then send it to us before the consult so we can have some time to go over that as we're evaluating the diet. Another tool that I like to use is a food diary. So some pet owners may not keep track of what their pets eat each day, especially if the food intake is varied. So maybe they're feeding a variety of different human foods. Maybe the pet doesn't consistently eat the same amount each day. And so what we can do is have them fill out a food diary, which just is a simple log of what is offered, how much is eaten, and how much is left over. And if pet owners can do that for a few days and send that back, we can then have a better idea of what that pet's currently getting. So that's another way to get a good diet history. And then I just want to point out the circle of nutrition. So that's this image here I have on this slide. And so there's 3 components that we really need to think about when we're getting our diet history. The first is animal-related factors. So that's factors specific to the pet, so signalment, breed, age, any medical conditions, any medications that pet takes, that type of thing. We also want to consider diet, and so that's what is actually fed, how much, are there any treats given, do they get table scraps, anything that the pet is actually consuming. And then the third part that we sometimes forget about is feeding management or environmental factors. And these things relate to whether there's competition in the house. How is that food actually fed? So is the pet meal fed during the day, or do they have free access to food? Are they fed from just a regular bowl or from a food puzzle? Do they eat other pets in the house food, that type of thing. So these 3 things are important when we're getting a diet history to really have a good understanding of that pet, what the pet's needs are, what they're currently eating, and then what the environment in that house is like. So going back to our extended evaluation, we then might want to review the medical history, and this could also include adding in some diagnostics. So if we're checking off some of those risk factors, for example, unexpected weight loss or weight gain, or a new medical condition, we might want to do some blood work, maybe a urinalysis, maybe some imaging, just to get a better understanding of that pet's medical conditions and whether there's any other things that we need to be thinking about. From that, we're going to then generate a problem list. And so this is a list of problems that the pet has. So for example, if we were to give a pet a score of a 7 out of 9, we would then add overweight to our problem list. From this problem list, we then want to identify key nutritional factors. So these are specific nutrients that we're going to be thinking about and that we're going to be using to compare diets and make a recommendation. So I learn best from cases, and so I thought it'd be fun to just go over a case and just give you an example of how we could assess a pet and then make a diet recommendation for him. So this is Pilot. Pilot is a 6-year-old male castrated boxer Mastiff cross. He is 37 kilograms. He's got a body condition score of 5 out of 9, which is considered ideal, and he also has a history of obesity. So we're going to go back to this risk factor checklist and identify any risk factors for Pilot. So I check off 2. Pilot lives in a house with a couple of other dogs and some cats. And we're going to check off previous or ongoing medical conditions because we know that he was previously overweight or obese. And so we're going to consider this a previous medical condition because it should be something that we take into consideration with his diet recommendation. So Pilot's owner likes to dress him up for Halloween, but also brings you this food and wonders if this might be a good food to feed Pilot. She says it looks nice and healthy on the bag. She likes that it's grass-fed beef and wants to know if this is an appropriate food for her dog. So I've got a question for you. I don't think the chat function's been working this morning, so you won't be able to actually put your answers in the chat, but maybe just think about this for a minute. What are the 2 most important pieces of information on a pet food label? So when you're going to pick a food for your pet, what information are you most looking for? So I'll jump right to the answer. So the 2 things that I think are most important are the energy density as well as the nutritional adequacy statement. So the energy density is important. That's going to tell you how many calories are in 1 cup or are in 100 grams. And that's super important because that's going to be how we decide how much to feed our pets. Foods vary quite a lot in their energy densities. So we could have one dog food that's 350 calories per cup and another food that's 450 calories per cup. And so if we were switching between foods and feeding the same amount each day, we could easily over or under feed our pet if we weren't paying attention to the energy density. The second important thing, which is even more important, is the nutritional adequacy statement. And so this may or may not be on a pet food label in Canada, but if it's there, it tells us that the food is complete and balanced. And so that means that the food is going to provide our pets with all of the nutrients they need in the correct proportions. It also tells us what life stage it's formulated for. So it could say something like adult maintenance, growth, or all life stages. And so this is really important because it tells us, 1, that we can feed this food and make sure our pet's getting all the nutrients it needs, and 2, what life stage it's intended to be fed for. So if we go back to this pet food that Pilot's owner wants to feed him, we look, and here is an example of a nutritional adequacy statement, and this is what it would look like on the bag. So it says this food is formulated to meet the nutritional levels established by the AFCO dog food nutrient profiles for all life stages. So this is an all life stage food. So is this appropriate for Pilot? Well, it's an all life stage food, so technically it's okay to feed an adult dog, but because it's for all life stages, it means it's formulated for the most nutrient sensitive life stage, which would be growth. So essentially this is a puppy food. This may not be a big deal for a normal healthy dog, but because we know that Pilot has a history of being obese, we may not want to feed him a food for all life stages because we may be providing him with too many nutrients and we could potentially easily overfeed him and have him gain weight again. So based on that, what diet should we actually recommend for Pilot? So we want to find a food that has a nutritional adequacy statement specifically for adult maintenance. Pilot doesn't have any other medical conditions. He has his history of obesity, but he's currently at an ideal body condition score. So there's no need at this point to put him on a weight loss diet or to look at other prescription foods because he doesn't have any other medical conditions. And the third thing is we really want to control his calorie intake to prevent weight gain, since we know he is prone to gaining weight. So for that last point, how are we actually going to do that? We're going to have the owner pick a food, or we might recommend a specific food, and then we're going to give a very specific amount of how much to feed. And so I just wanted to talk a little bit about how we measure food. And so what we know is that a measuring cup is actually not the most accurate way to measure food, and we can actually very easily over or under feed our pets if we're using a measuring cup. And so the best way to measure food is to use a gram scale. There are several different types of gram scales that you can buy, and so you can get these little tabletop ones where you put the bowl on top and measure out. You can actually buy a bowl that is a gram scale and you just add the pet's food into the bowl, or you can get these scoops that actually weigh how much you're scooping in grams. And so this is a much more accurate way to measure out food. Lastly, how do we feed? So a lot of pet owners might choose to just feed in a typical bowl. This is what I used to do. Now I feed all my pets in food puzzles. The benefits of these is one, that it takes them longer to eat. So Pilot usually takes about 30 seconds, maybe less, to finish his whole food. If I put it in a food puzzle, that's lasting at least several minutes for him to finish his meal. So it's helping mealtime, which is his favorite time of day, last a little bit longer. And the second thing is it's providing some mental stimulation. So it's making him work a little bit more for his food. There are several different types of food puzzles. You can purchase them, or you can be creative. Like this one at the bottom here, you can use a muffin tray with some tennis balls. Not just for dogs, there's lots of food puzzles out there for cats as well, because they also benefit from slower meals and from the mental stimulation. So once we make this recommendation, we pick a food, we recommend a dose or a food amount, we recommend how to feed this food. We're not done. Anytime Pilot comes back for a visit, we should again reassess his nutritional needs, reassess that circle of nutrition, and identify any new risk factors that are there. We want to assess his body condition score at each visit, and then potentially change our plan or make a new recommendation if anything else comes up that we need to pay attention to. Thank you very much for inviting me to speak today. I hope you enjoyed that. If you've got any questions, I'm also happy to have you email me if you've got questions. And I just want to again thank Purina Pro Plan for sponsoring today's session.
Just a small town girl living in a lonely world. She took the midnight train going anywhere. Just a city boy, born and raised in South Detroit. He took the midnight train going anywhere. A singer in a smoky room, a smell of wine and cheap perfume. For a smile they can share the night. It goes on and on and on and on. Strangers waiting up and down the boulevard. Their shadows searching in the night. Streetlights, people living just to find emotion, hiding some Your lipstick stains on the front lobe of my left side brains. I knew I wouldn't forget you, and so I went and let you blow my mind. Your sweet moonbeam, the smell of you in every single dream I dream. I knew when we collided, you're the one I have decided who's one of my kind. Hey, soul sister, ain't that Mr. on the radio? Stereo, the way you move ain't fair, you know. Hey, soul sister, I don't wanna miss a single thing you do tonight. Hey, hey, hey. Just in time. I'm so glad you have a one-track mind like me. You gave my life direction, a game show love connection we can't deny. I'm so.
Hi everyone. Next we have Dr. Michelle O'Black, who is a clinical researcher and associate professor at the Ontario Veterinary College. Dr. O'Black is an active researcher with a focus on translational research, and she has several collaborations considering dogs as a naturally occurring disease model for cancer in humans. Her research focuses on comparative oncology, including osteosarcoma, innovative methods for staging and treatment of dogs with cancer, including sentinel lymph node mapping, image guiding therapeutics, and interventional methods for the treatment of prostate cancer. A recent landmark accomplished was the involvement in the development and implantation of the first 3D printed skull plate in a dog. Patches, the dachshund, captured hearts around the world and was featured in several media outlets, including CNN, the New York Times, and BBC News. She continues to focus heavily on 3D printing in her research, working with a group of researchers at the OVC who have similar interests. Their goal is to make 3D printing accessible to veterinary patients while ensuring the highest integrity and science behind its use. Michelle is a passionate veterinarian who loves the work that she does. As an OVC graduate, she is a strong supporter of the OVC community, and she loves getting to work with students who will become future colleagues. We would like to acknowledge TD Canada Trust for sponsoring this talk. If you have any questions throughout the talk, please send them to vetmed@uoguelph.ca, and we will answer them during the live event. Please welcome Dr. Michelle O'Black.
Wonderful. Well, welcome everyone. Last talk before lunch, so almost break time. But I just wanted to say thank you so much for the opportunity to be here today to speak with all of you. And I wish we could be meeting in person, but hopefully we'll have a chance to meet in person soon. So today I was going to speak with you a little bit about 3D printing and how we're using 3D printing in veterinary medicine. And so just as a start, one little bit of housekeeping is just to clarify some of the terms around 3D printing. You may have heard these terms thrown around, but essentially 3D printing or additive manufacturing are used interchangeably as a group of techniques really to take your digital design and turn it into something you can print. So 3D printing in itself has a lot more involved than just sort of going ahead and printing something that you come up with as an idea. There's a lot of steps in between, and so that process of creating that digital design and then turning it into a file is sort of that 3D printing additive manufacturing technique. From there, you're going to actually create the prototype from the rapid prototyping. So that's where the rapid prototyping comes in, and you're going to find that probably I, without realizing it as well as anyone else will, quite frequently use these terms fairly interchangeably, but essentially 3D printing or the AM process is the process, and then the rapid prototyping is the result that you get. So believe it or not, 3D printing has actually been around for quite a long time. So 3D printing has been around since the 80s, and the first 3D printer was developed in the early 80s, And at that point, it was a huge printer that could print a very, very small object over a very long period of time. So as the technology improved, 3D printing moved into medicine actually not too long after it was created. So in 1999, the first time 3D printing was used in medicine as an implant was actually in creating a 3D printed bladder. So as you may be aware, the bladder essentially is like a big balloon, and so it was a great product to start with in terms of being able to create something that could be used implanted, because it doesn't have a lot of functionality in itself. And so essentially they were able to use the 3D printed bladder in a bioprinting fashion, so compatible with the body, and implant it into the body. Not too long after that, they were able to create and 3D print a functional kidney. Now these haven't been put into people yet, but that's something that's kind of coming down the pipeline. And surprisingly, it took till later for things like custom 3D printed prostheses to be developed and designed, likely related to where the funding was and the technology at the time. A really big landmark for 3D printing was actually in 2009 because the patents expired. And so suddenly there was this explosion of availability for 3D printers. And now really you can get a 3D printer that is a few $100s that can sit on your desk. And moving forward still, within the last 10 years, they've started really printing implants and things like that. And it was, really only about 10 years ago that they first were creating implants that could be used in people. So why use 3D printing in medicine? So really what's cool about 3D printing is it's ultra personalized. You can use it on demand. It really increases the opportunity for solutions around design. It allows for international access, which is something that otherwise wouldn't be available. It really improves the manufacturing speed and efficiency when you're trying to produce something at a very low scale. 3D printing still isn't able to take over for machining and things like that when you're talking large scale, but on a smaller scale, there's definitely opportunities to not have to go through the die cast models and all of the things that are involved with creating something on a larger manufactured level. There's also a lot less waste and a lot less costs, and so it's a much more sustainable technology. 3D printing is an amazingly large endeavor in general, and so believe it or not, it's actually about a $35 billion industry, or it will be in the next couple of years, and so it's a huge industry, and I think really is still growing massively. On the animal and human side, from a medical perspective, they're actually estimating that about 25% of medical devices will have some sort of 3D printing component to them by 2023, so only a couple of years away. And already, most of the large human hospitals in the US do have 3D printing associated with how they do their care. So when we talk about 3D printing, it's important to understand kind of what materials we can use. So plastics are going to be your most common, and you can see, as an example here, and that's the same example in the picture. Think about what type of skull this is, and we can talk about that at the end. But this is a very simple, very light prototype of a skull. And so this is kind of a really nice example of plastic 3D printing. And so plastics are definitely the most widely available and the most accessible form of 3D printing. But we can actually 3D print in metal as well. There's some newer technologies to use carbon fiber as well as ceramics, which is pretty neat. And then what's kind of coming down the pipeline, it's still very infant stages, but likely will be something more accessible in our lifetime, is related to bioprinting. And so that's actually using human or biocompatible cell structures and implantable technologies that way. So we can actually create scaffolds on naturally occurring tissues and things like that and actually print with cells themselves. So for today, I wanted to sort of talk about briefly 4 different areas that we're really using 3D printing in veterinary medicine. And so the first one is educational models. So using those models, similar to what I showed you here with this skull, using those models as a training tool, so helping with anatomy and understanding, helping with sort of people who are more tactile learners to understand, and that's where training tools become very important. So in a situation like this skull, I could actually use this to help to train on a particular technique. I could use it to help learn things like how to remove teeth or things like that. So it can be used quite a bit for training. We can use it for preoperative planning. So if we have a specific patient that we want to evaluate a disease process and plan for a surgery. And then we can also do it for specific solutions related to patients as well. So from an educational model perspective, what you can see on the screen here is on the far left of the screen is an image of a heart. And so that heart is sort of the output that you get if you create a CT scan or an MRI scan, depending on what you're using for a heart model. And so we can actually take that information and we can translate that with different technologies and softwares to actually create a model that is visibly able to provide information about anatomy. Now, this is a pretty advanced model. This isn't going to be a model you can easily create on a standard printer. This is a pretty expensive and fancy printer, but pretty cool technology that we can actually have clear resin that can print and allow us to get a window and a look into the different components of the heart. As a training tool, there's so many different opportunities. This is a really nice example from one of our radiologists, Dr. Zerlinden. And so he's actually created a phantom for ultrasound. And so when you're learning a technique like ultrasound, there's a lot of things that need to go into that, how to hold the probe, how to read the image on the screen. As you'll see on that image on the left, essentially it looks like a bunch of black and white. And so understanding and learning what that looks like, what that means, you don't necessarily need to do those things in a patient situation. You can learn how to hold the needle, how to hold the probe, how to evaluate the images without actually having to have a patient involved. And so this is a great example of where they actually 3D printed the model and then they cast silicone into that in order to make it something that can be used in an environment where you're able to see ultrasound through it. So you can use the 3D printing directly to create your tool, or you can use it to help create molds and things for your tools. From preoperative planning, this isn't our patient, but pretty cool example of Rhino who actually had a abscess, a tooth root abscess. And so starting with that CT scan, they were able to sort of evaluate and see what was going on in that patient. And then from there, they could plan the surgery ahead of time so that when they actually got to a point where they were doing the procedure, it could be as quick as possible. And this is really where we're utilizing a lot of the aspects. And then finally, from the perspective of specific solutions, a nice example of a dog that had a pretty severe tumor on his face that was going to require extensive removal. Again, not my patient, but a nice example of how they were able to reconstruct the patient's architecture and the facial structure. Another nice example of being able to utilize, this is a puppy that was hit by a car and had severe fractures of the face and skull. And so using 3D printing, they were able to create basically a mask that would allow the dog to continue to grow and help to recreate and restructure so that as the bones were growing, they would grow back towards the normal position. A really nice example as well that's been used quite a bit is a pretty simple one. So these are in animals that have had, the top left one had a bite from, I think it was an alligator, but basically lost the top part of the beak, and they were able to print a beak in order to allow that bird to have more function. Same with that parrot and the turtle as well. And so obviously these are not animals that we're now going to release into the wild by any means, but it is given us an opportunity just to be able to provide more function, improve comfort, and improve cosmesis for these animals. A final nice example is with limbs. So you may have seen some of these. I think the duck made headway a lot through the internet, but you know, being able to allow these guys to improve their function and get around. And so looking at solutions for often exotic patients or animals that are in a rehab facility that have lost limbs and can't function very well without it, providing some sort of a structural support to help them with that. And so we'll talk a little bit briefly about a couple of examples sort of from our own work. And so what I think is really important to understand when we look at 3D printing as a mechanism is sort of how does it work in the medical field. And so we first start out with getting some advanced imaging. So you've probably heard of a CAT scan or an MRI. We have access to both of those in animals as well. And so we're using those to essentially create a 3D model of the patient. So with the CT scan or the CAT scan, it creates very thin slices of images that can be stacked on top of each other. And ultimately then all of those images together can create that image that allows us to see what's going on in the patient in a 3D form. From there, we have to use some specialized software that allows us to actually view the images that are output from the CT. When we're looking at involving a patient and planning for a patient, from there we involve myself and a radiologist. We work together to evaluate, if in this case, tumor margins and figure out, okay, where is this tumor based on the advanced imaging. So this so far is all just background work that needs to go in before we can even think about doing any sort of 3D printing. From there, we then have to employ a design engineer who can help us to do some 3D modeling, help create the area that we're going to be removing and define that based on the CT scan and the information that we got. From there, we create that defect and then we work with different softwares in order to create an actual plate. And so in this example that you're seeing on the screen, this is in a patient that has a skull tumor, and so you can see in the middle image is the image that you would see on the CAT scan or the CT scan of the tumor, which is that very large bump in the middle. And we've defined the margins of that tumor with those little dots that you can see to make sure that when we plan our surgery, we're not going to be invading into that tumor because we're trying to remove it completely. The next image is basically what we would be planning from when we're looking at the 3D component of things. And then from there, following that image along, you've got the defect that's been created, the creation of the plate, which then can be printed on a metal printer. So when we do metal printing, it's a pretty cool process. And so essentially what happens is it's a metal powder that's laid down, and then it's a process called sintering. So with lasers and heat, the layers of that powder are melted together, and then layer by layer by layer, the item is created. And so as I'm sure you can imagine, depending on the thickness and the size, that can be a pretty long process, a pretty involved process. And so these aren't printers you're going to be buying on your first kind of go around with 3D printing. These are going to be more advanced medical printers, but it's pretty incredible that we can actually create titanium or stainless steel or cobalt chrome. We can actually create an implant that goes along with that. So once we have that initial print, you can see on the bottom left of that image is the print with the scaffolding. So we need to print things with the scaffolding to make sure that they're not getting squished and flattened. So then we have to remove all that scaffolding, and then the image on the right is showing you the plate before it's had any sort of processing. So just removing that scaffolding to help us sort of start from there. And then from there we can move into the final process. And so here is Patches, who is the patient that we mentioned at the beginning. And so she presented with a very large tumor in her skull. The tumor was quite involved, as you can see in that middle image on the CAT scan. All of that bright white is tumor. And so in removing that, we knew we'd have a really big defect that we would be creating. And so in her case, we ultimately employed and looked for the help of our team to create that 3D plate. And so on the second from the right image is the plate that we had printed, which allowed us to remove that tumor and then place that plate on top to protect her brain, because that whole area around the skull would be her brain. And then on the far right, you can see Patches at the time of her stitch removal about 2 weeks after surgery. So she's not perfect, but she looks pretty good. So the other cool thing with these types of cases is we can actually print that skull. So that is Patches' skull. It's an exact replica of her skull, and so it allows us to plan for the surgery, helps us to get a good understanding of the anatomy and the distribution of what we're going to be working with, and then we can kind of practice the surgery ahead of time so that once we actually get into surgery, we're ready to go. And this is Patches about 6 hours after surgery. So pretty incredible pretty big tumor, big surgery, but she did it very, very well. And as you can see, you know, cosmetically, she looks quite good, considering how big that tumor was. And so 3D printing really allowed us to create something that could provide a lot of support for her, make sure that she didn't have any risk of getting damage to her brain at the time of, you know, running into anything, or if someone pat her on the head too hard, and really allowed her to go on to have a really good quality of life. This is another patient that we did more recently, about 1.5 years ago. Just another nice example of this dog had a pretty large tumor that was growing out of his sinus and around his brain. You can see here, we were able to use that 3D printed model to help us plan our surgery and take that into surgery with us. And then this is the plate that was created for him. You can see we had a special guide to help us with how we were going to make those cuts to make sure the plate was going to fit during surgery, and then we took all the tumor that you can see below. And then this is him immediately after his procedure. So he's still asleep right after surgery. And then this is him about 1 year later. And so doing very, very well, and never really looked back. So pretty incredible that we have the opportunity to provide this sort of advanced care for these guys. So what about the future? So, you know, they're really, at the end of the day, 3D printing is really only limited to the imagination. So, you know, I think as we move forward with this technology, we're going to start to see a lot more implants and ways to reconstruct things. So that image on the far left was actually used to reconstruct the sternum bone in an individual who had cancer of the sternum. And so they were able to reconstruct that rib cage and have good quality of life there. That middle image is a 3D printed ear, and so I do think that we're going to start to see a lot more bioprinting and things like that. And so obviously along with that comes a lot of questions of ethics and morals and things, and what should be done and what can be done. And then another kind of really interesting application for 3D printing is that for medical tools that are expensive and inaccessible in developing countries, a lot of these materials can actually be sterilized, and they can be used once or twice or even just once as a disposable tool for a few pennies. And so it can be a very inexpensive way to provide access to certain level of care that sometimes wouldn't be available otherwise. And so with that, I'd just like to say thank you so much to Canada Trust for sponsoring this talk today. And just to, you know, our team, you know, very much as I've mentioned, 3D printing is a team effort. And so there's a lot of work that has to go into all of the development and planning, as well as kind of sorting all of that out. And so if you do have any questions, I would encourage you to send them in. I'm happy to take a few moments to answer those. And thank you for your time, everyone.
Les rêves des amoureux sont comme le bon vin, ils donnent de la joie ou bien du chagrin. Affaibli par la faim, je suis malheureux. Au longtemps chemin, tout ce que je peux, car rien n'est gratuit dans la vie.
Hey everyone, Michael here. You might remember me from some of your asepsis videos, but today, instead of showing you how to prepare a plastic box for surgery, we're going to be going over how to make supper. Now, this is a quick and easy stir fry that won't break the bank. Really, the only thing that's hard about it, for me at least, is the part where it says serves two. Moving on, before we get started with the cooking, we're going to want to get all our ingredients in order. So I've got some cooking oil, sesame oil, tofu, broccoli. By the way, all the ingredients are in the description below. Some green onion, 2 cloves of garlic, some soy sauce, black pepper, and cayenne pepper. Now, this stuff is absolutely lovely with some rice, so I've got some simmering away in a rice cooker off camera. Now, if you like unnecessary work and inconvenience, you can also cook your rice on a stovetop, but we have standards in this household, so we're not going to do that.
Right, so first off, you're going to want to take your tofu out of the package and use a paper towel to pat it dry until it's, well, drier than my DMs. Once you've got that done, you're going to actually want to cut it up into bite-sized pieces. So, because we are working with a rather sharp blade, please do be careful. We don't want any surprise declaw surgeries happening in the kitchen. Once we've got that done, we're gonna move on to the broccoli. Now this part's quite straightforward. You're just gonna take the broccoli in your hands, break it up, and really just tear it apart. Kind of like how your heart feels after that really cute girl leaves you on red. Not to worry, I am definitely not speaking from experience. Okay, once you've got that sorted, we can move on to the garlic. So first things first, you're gonna actually want to peel the stuff. Once you have both cloves peeled, you can take it to a grater and grate it up. If you don't have one of these, a kitchen knife gets the job done as well. Right, so once you've got that sorted, you're going to want to move on to your green onions and also chop those up into real small pieces. And once you have that done, we can fire up the stove and get started with the cooking. So for this recipe, I am using a cast iron wok, but a non-stick one gets the job done as well. To start, I am pouring some canola oil into the wok. You can really use any form of cooking oil, but I like canola because it has a really high smoke point, which makes it very well suited for this sort of high temperature cooking. So to begin, I'm just putting the green onions and the minced garlic into the wok along with the cayenne and black pepper. And we give that a good stir with a spatula, and once you hear it sizzling nice and loudly like it's doing now, we can put in the broccoli. Now keep in mind that if you're using an induction stove, this step may take a little bit longer because those are a little bit slower to get up to heat. Okay, so you're just going to pop your broccoli in there, give her a good stir for about a minute or so, and then we can move on to the next step. Okay, so once that minute is over, you can take your chopped up tofu and pop it in the wok alongside the broccoli. Now, when you're stirring it, you can do it with a spatula like I'm doing now, but let's say you have a date over, or you want to show off in front of your friends, what you can do is actually grasp both handles of the wok and start tossing it around like so. I'm not very good at it, so I'm just going to be sticking with the spatula for this recipe. Alrighty, so once your tofu's been in there for about a minute, you can move on to putting in your 2 tablespoons of soy sauce. Once that's in there, you're just going to want to take your spatula and give her a good stir till it's spread around nice and evenly. Alright, so once that's done, we can add the sesame oil. Okay, so the amount of sesame oil you add is really down to taste. I usually add about a teaspoon or so, but again, it's up to you. Take your spatula, give that another good stir, and yeah, you're good to go. Alright, so once your stir fry is cooked, we're not quite finished yet. We want to make it look pretty, so we can put it on Instagram, flex it on our friends, and get that external validation that we all so desperately and unhealthily crave. So to do this, we're going to get some of those green onions that we chopped up earlier and sprinkle it on the rice to add a splash of color before plating the stir fry itself. We're going to garnish all that with some sesame seeds, and there you have it. Tofu and broccoli stir fry ready to go.
All right, hello everyone. First off, I would like to personally thank everyone for attending today. I hope you are all enjoying the day so far. My name is Christina Mozon, and I'll be introducing Dr. Madden and Dr. Tomlinson, who are going to give the next presentation titled Species Survival: Anatomical Perspectives. Professor Pavneesh Madden is a faculty member at the Ontario Veterinary College, University of Guelph in Ontario, Canada. Dr. Madden did his Bachelor's of Veterinary Science in Animal Husbandry and Master's of Veterinary Science at the College of Veterinary Sciences in Hisar, India, and pursued his doctoral studies at the University of British Columbia in Vancouver, Canada. He completed his postdoctoral training at the University of Western in Ontario, Canada. Dr. Madden also passed the Canadian equivalency exams to continue clinical practice and is cross-appointed as a veterinarian at OVC's Primary Healthcare Centre. His research interests include understanding pre-implantation embryo development, embryonic failure, and in developing markers for embryonic health. Dr. Madden is a recipient of several research and teaching awards, which include Elizabeth Roxanne Howland Fellowship and Wyeth Award for Research Excellence, which were both awarded 3 times. He is also a 2-time winner of the Pfizer Carl J. Norden Distinguished Teacher Award, which is the highest teaching award in the field of veterinary medicine. He is also a recipient of the peer-reviewed University of Guelph Faculty Association's Distinguished Professorial Award. In the DVM program, he teaches abdominal and thoracic anatomy. Dr. Jeff Thomason was educated at the universities of Cambridge and Toronto and does research on the anatomy and locomotory and biomechanics of horses. He's an award-winning educator who has led the anatomy team of instructors since 1994. This year's edition of the team, including Dr. Madden, must be recognized for delivering the COVID-19 version of anatomy, which has as much in-lab time as possible. Normally, we would offer you a look at the lab experience, but instead, you are about to get a feel of the other side of what teaching is today, an online lecture. If you have any questions throughout the presentation, you can email them to vetmed@ulguelph.ca. Enjoy.
Thank you, Christina, for that wonderful introduction. And personally, I would like to thank the whole class for including me in today's celebration of family and friends. And before I go on to my presentation, I would also like to acknowledge that this has been a tough year, and thank you to all the students for being so cooperative and supportive in this very modified teaching format. So today, the title of my presentation, and along with me, Dr. Jeff Thomason, is about species survival through anatomical perspectives. And interestingly, anatomy plays a critical role in the species survival. And I can tell you that there are 2 important things that happen during lifespans of animals, that is sudden mutations and also adaptations that happen along the way, which help them to maneuver their way through difficult times. If you look at this left bar here, or the column, you'll find that this is the phylogenetic tree of different species and how different species have evolved over a period of time, the most primitive ones being at the top and the most refined where the humans are at the bottom. And you can see the connection of each species with one another over a period of time. And what I want you to really focus on in this small area where most of the domestic species are present. And you will be delighted to know that both dog, cat, whales, cows, pig, and horse are very, very commonly connected to each other through the genomic studies that we have found out that they are genetically, they've lineaged out of the same path. And when we look at this whole scenario of how the modifications have played a role in determining how the species have adapted along the way, there's a very interesting phenomena which I'm going to share with respect to going back in time. And if we really go about 36 million years ago from today, and that's the Paleocene era, the ancestral proto-ungulates were already present, and they had both the precursors of the bovids as well as the equine species. And you'll notice that around Oligocene era, which is 38 million years from present, most of these density of the equid species called the perissodactyls at the time was fast depleting. And you can see only 3 of those 5 have actually survived to modern times. And while this was diminishing on the left side, where you see the brontotheres being completely gone from the planet Earth, something was happening on the other side where the artiodactyls were present, and you can find that their density was not only increasing, but their numbers were increasing, their different subtypes were increasing, and they were writing their success story, and that led to the survival. So what is that? That something was leading to depletion of the equids while survival of the cows, and that goes down to the grassland and how they modified, these species modified to work with the food at that present time to lead to the survival. Jeff is going to follow later on talking about how the legs played an important role in the survival of that species. So over to Jeff.
So quickly, this is a follow-up to the previous slide showing you what's happening in time, and you'll see the list of features up the left side. And basically the one point I want to make from this is I'm going to talk about some fairly major changes in the limb anatomy within about 2 minutes, but those changes took 55 million years to take place, and they didn't all happen overnight, and they didn't all happen at the same time. And that's the whole point of this slide. We're looking at a long period of slow change.
So with that, I'm going to stop sharing the slides so that I can just take you right to the specimens. And first specimen I want to show you is from a cow. This is the digestive tract of a cow. I'm going to just lower the screen a bit of it. And I think everybody has just returned from lunch, so it's quite fitting that we are talking about the digestive tract and how the cows adapted to grasslands and how it's different from equine, and how anatomy plays an important role. So the food actually, when it comes down from the esophagus, gets into this small little hole, which is the esophageal opening, and it falls into this compartment, and that's the rumen and the reticulum, which occupies the complete left side of a cow. And today probably will be the first time when a lot of you will be able to get a sneak peek inside a cow's stomach. And Sarah's going to help us with shining some light straight into and you can see how those are little compartmentalized into areas where food is broken down into smaller components. It's churned, broken down further before it gets into this dome-shaped structure called the omasum. And from omasum, it goes into the next chamber, which is this J-shaped true stomach. And that is where the enzymatic digestion actually happens. So what smart thing cows did was they modified their esophagus into these three compartments, rumen, reticulum, and omasum, which was able to do the fermentative digestion, because a lot of the grasses can't be digested by enzymatic digestion. So they basically did the fermentative digestion to ferment the grasses, break them further down, and also produce energy in the process. And then finally, the food was digested using the enzymatic digestion. On the contrary, horses had a different plan. They went with the fermentative digestion, but towards the later end of the body. And all the modification they did was towards their ascending colon. And therefore, if you compare cows and horses to cars, then cows would be a front-loaded engine kind of a car, and horses would be the rear-end Ferraris of modern world, because they have an engine which is loaded towards the rear end, and that is the fermentative digestion happening in the cecum and the ascending colon. Here is the cecum, which is a comma-shaped structure where a lot of fermentative digestion happens. You'll be surprised why I'm holding a very small gut, because it's from a very small pony. It's so much easier to maneuver, but in real life, this would have been many more times bigger, and it would have been very hard for me to move this around. And from there, we have this whole modification of ascending colon, which is present in big loops to accommodate inside the body, but that's where all that fermentative digestion is happening. So the question comes, where does the enzymatic digestion happen in horse? So they have actually a true stomach, which is way ahead in the body, and that's where the enzymatic digestion happens, but all the fermentative digestion happening at the end. So that was about the comparison between anatomy and how these modifications helped them survive over a period of time. With that, let's go and take a look at limbs, and Jeff is going to do that.
Thanks, Patnish. So my first question for you is, can you imagine carrying around those two huge segments, whether it's stomach or intestines, both filled with slopping juices and weighing, in terms of the rumen, probably well over 100 pounds? And this is an animal that migrates. Both horses and cows are migratory animals. So they've got to carry these huge guts around for many hundreds of miles when they're migrating and looking for food sources. So to be able to do that, they've got to do it efficiently, because the whole currency of evolution is saving energy. Because the more energy you save from moving around or from digesting or whatever, the more energy you save from those processes, that leaves you more energy to reproduce and leave offspring for the next generation. So energy savings are really important. And what we see in the legs is ways of saving energy. So when we just look at this whole skeleton, if you look at the whole skeleton, look at the size of the trunk, and then look at these long, skinny legs. And you may think they're not strong enough to hold the animal up, but they are. And the reason for being skinny comes back to this demonstration. So here's an animal with a long leg, but not a very skinny one. It's got a very big foot on the bottom end. I hope you can see that. Oh yeah, it should be there. So this is an imaginary leg, and that's, given this being a heavy hammer, that's about as fast as I could move it. So if I've got a lion on my tail, I'm going to be the lion's dinner. On the other hand, if I simply move the weight of the leg to the top, now I can run away from the lion. So that's one main principle in leg design. The big muscles that drive the legs are up here, and down into the leg you get long skin things. Where's my next? Was there a second ago? There it is. So the other thing that these animals do is they take their fingers, and we use our fingers for grasping and picking things up and doing fun things with fingers. What they do is they land on their fingers and bounce off them. So in the tendons down the underside of the finger that we use for grasping, they use for bouncing off. So what they're doing is, as they land, they stretch out the tendons, and then the tendons release and catapult them in the air. And those springing tendons save them roughly 20% of the energy. Can you imagine your car using 20% less gas? You'd be kind of pleased with that. So where are these tendons? Oops. I'm coming back. I am coming back. If you were wondering why I had gloves on, now you know. So this is a dissected pony leg. Sorry, straight after lunch, but that's how it is. This is an anatomy class. You've got to get used to that. So here are the muscles that I'm talking about that move the arm. Here's the muscle to the shoulder, and I'm holding the muscles that move the fingers way up on the arm. And look at these long tendons. There's a fairly skinny one right there. If I turn this round, and this is a pony leg, so it's really kind of small, but you can see there's 2 or 3 fairly big tendons, so that when I straighten out the foot, or attempt to, you should be able to see these tendons on the back of the leg stretching and releasing. And essentially the horse is bouncing, like we bounce on tiptoe, the horse is doing it, instead of round here, it's doing it down by the, this is the sort of your knuckle joint, so it's way down on the leg. And they bounce off these tendons, off they go quite happily. And then you may wonder, okay, what do the cows do? The cows do pretty much the same, except, I'm coming back again, here's the very obvious difference. I hope you can see that. I think that's showing up pretty well. That's all right, I've got it. If you can count up to 2, which I'm sure you all can, you'll notice that the cows on this side have 2 toes, which you knew already, I'm sure, and the horse has 1. And the reason for that is unknown, because they both have very similar tendon mechanisms, but the horse does it on 1 toe and the cow does it on 2. Who knows why? Maybe the twin hooves give them better grip on slippy surfaces, I don't know. But the take-home message is they've got these huge guts for fermentation. They've got a very effective locomotory mechanism for carrying that heavy gut and heavy body around. And we're doing quite well for time, so what else do we need to say?
Yeah, I think that's pretty much what we had to present to you. Thank you so much for your attention. I wish we could have had a more interactive platform and take a few more questions from you. But if there are questions, some of us are on the social media. Connect with us on the social media. And here's Sarah for a quick hello.
Hi. I just wanted to, having acknowledged the class, I want to acknowledge our really great backup team of staff, of which Sarah is one, who gave up a Saturday to come and help behind the scenes.
Yeah.
Thank you.
Thank you so much. Thank you, everyone.
And thank you all for listening. Hope we didn't put you off your lunch.
Thank you, Kevin.
That's a wrap.
Hey guys, it's Michael again. So now I'm going to share with you this really neat story of how OVC actually came into existence. So our story begins in a place in Scotland called Ayrshire. Now Ayrshire is the birthplace of quite a few notable Scots, such as Robert Bruce, Robert Burns, and Alexander Fleming. But we're not going to be talking about any of them today. We're talking about a guy called Andrew Smith, who was born there in 1834. Now, Andrew is born into a farming family, so he spends most of his early life working on a family farm, but he does end up going to the University of Edinburgh, where he studies to become a veterinarian. Now, Andrew Smith, or Dr. Smith, I should say at this point, graduates in 1861. Now, in 1861, Canada has far too many farm animals and not enough veterinarians to care for them. So, Andrew goes off to Canada, and in 1862 begins delivering a series of lectures on farm animal welfare. Now, these lectures become so popular that in 1864, he creates a dedicated 2-year program, at the end of which you receive a diploma and you basically be a veterinarian. Now, it's quite a bit shorter of a path than what we do nowadays, but that's alright, times change. Now, at this point in the story, I want to take a pause and share with you a really cool anecdote from this era. Now, as I'm sure many of you can guess, having a strong understanding of anatomy is really important if you want to be a veterinarian. Right, you gotta know what your patients look like on the inside and on the outside. In today's day and age, we do so by doing dissections, where we go off to a dedicated lab, our specimens are all kept in a refrigerated room, we take them out when we need them, we put them back when we're done. That's all well and good. But in the late 1800s, their refrigeration technology was not nearly as good as what we've got today. So the way that they prevented their specimens from decomposing was that they would actually do all their dissections in the month of November in an unheated shed outdoors. I'll put a picture of what that looks like here somewhere when I'm editing the video. But anyways, when I read that anecdote, I all of a sudden became very grateful for the advances in refrigeration technology that have happened like the last 150 years or so, and the concurrent increase in veterinary student effort that has accompanied it. Now, moving back to our story though, at this point in time, the school is actually known as the Upper Canada Veterinary School. It's not until 1897 that it actually rebranded itself as the Ontario Veterinary College. Nonetheless, Dr. Smith continues serving as its principal until 1908, at which point he retires. Now, it's important to know that kind of everything that's happened in our story thus far has been happening in Toronto. It wasn't until 1922 that the school actually moved to Guelph, where it is today. And now, I've attached some images from my own private collection. These are just some postcards that I've got lying around. And they show some of the changes and renovations that the school has gone through over the years. But one thing I think that hasn't changed is the school's dedication to advancing scientific understanding and improving animal welfare. So, with that in mind, I hope you all have a great day. Take care. I'll see you around.
So I'm here to introduce Dr. Ryan Appleby. Dr. Ryan Appleby is an assistant professor of diagnostic imaging. He is an OVC 2014 graduate and completed a rotating internship at OVC and a diagnostic imaging internship at the Veterinary Imaging Center of San Diego before a residency in diagnostic imaging at North Carolina State University. He has been thrilled to be back at OVC teaching, doing research, and practicing as a radiologist in the Health Science Center. We'll take a moment to thank Wren's Pet Depot for sponsoring this presentation, and a reminder to everyone that if you have any questions throughout the presentation, to feel free to send an email to vetmed@uoguelph.ca. And without further ado, Dr. Appleby.
All right, thank you so much. It is a pleasure to be here today, and I'm really excited to talk to you about some adventures in veterinary radiology. So when I was asked to give this talk, I thought that I would focus it on some of the weird and wonderful things that our wonderful furry family members get into. So the dog ate what? You know, it's not just the dog. I've got some examples of cats in here, and I think we're gonna have a bit of a good time. So without further ado, let's get going. I wanted to kind of start by giving you a little history of Family and Friends Day. So this is my own Family and Friends Day over a decade ago, and my parents got to participate in a sort of a rite of passage for, I think, the family members of many vet students that unfortunately, that due to COVID, that all of you don't have the opportunity to participate in. So this is a cow with a fistulated rumen. I'm not sure if it's been discussed already, but this is one of the both a teaching and a method for us to be able to do kind of ruminal fluid transpositions for patients, and there was an opportunity to get into that and to understand this at our Family and Friends Day, and my dad had the opportunity to actually put his hand in a cow's stomach, which is a fun and exciting thing. But you know, one of the main reasons I brought this up is that as I thought about giving this lecture, one of the things that I remember is that my parents, as I went through this path, really never had a great understanding of what going and becoming a veterinarian was, and especially too when I went on to become a veterinary specialist. So I appreciate the introduction, but I wanted to take a little bit more time just to educate some of you on what it's like to kind of move through. And some of this you're going to be familiar with, and some of it might sound a little bit foreign. But this is kind of the path of a veterinary specialist, and I'm going to use my own example to kind of anchor that. So I was born and raised in Toronto, and as I'm sure many of this class are, and I went off to school at the University of Western Ontario. I was a proud Mustang, but I wanted to become a veterinarian. So after finishing my BSc, I moved back to Toronto. I worked in a small animal clinic, as I'm sure a ton of folks here have. And then I was lucky enough to be accepted to the Ontario Veterinary College, as all of your the student veterinarians that all of you are associated with have been. And so I joined the OVC and I got my DVM. And so for most veterinarians, this is where the journey stops. This is the end of it, and it's more than enough work, right? You've done undergrad, you've done a DVM, you're exhausted, and that's it. And that's a wonderful place to be, and some of the most important members of our society. But for some of us, it goes a little bit further, and I'm not sure if it's a glutton for punishment or just a real desire to learn something incredibly specific and specialized. Some people go on to do a companion animal internship, and this is what I looked like before an internship, and obviously things have changed since then. I think I was bright-eyed and bushy-tailed, and I did my internship here in OVC as well. And then I went on to do a second internship. So some folks are lucky enough to leave an internship and go straight into their residency. I had to do a second one, and for me that was in San Diego, where I was lucky enough to work at the Veterinary Imaging Center of San Diego. It was a wonderful experience. And this was a radiology specific internship. So you kind of start off with a rotating internship, you do a little bit of everything, and then you might specialize a little bit further. And for me, that was in diagnostic imaging. But you know, if you're interested in a different specialty, it might be a specialty internship in that specific thing. And then, of course, I went on to the North Carolina State University, go Pack, and I became a diplomat of the American College of Veterinary Radiology following a residency, which was a 3-year program there. And now, of course, I'm lucky enough to be back here and talking to all of you today. And so what is veterinary radiology? You know, I go through all of that, became a veterinary radiologist, but what is that? What are we doing? Well, this is the study of imaging in animals, and we use radiographs, ultrasound, CT, and MRI, and a little bit of nuclear medicine to help image either pets or other animals that come to veterinary clinics. For veterinary students, most of what they learn is radiographs and a very small amount of ultrasound. We touch a little bit on some of those more advanced imagings, the MRIs, the CTs, get taught a little bit of that, especially as it relates to neurology, but there isn't really a focus on learning to interpret that. And that's sort of reserved for those of us who go on with a little bit of extra training in it. In first year, folks learn anatomy, and we're going to talk a little bit about that today, and I hope you're excited to kind of see what the inside of a dog looks like. In second year, we start to talk about what's abnormal for our patients. So we've foundation and normal anatomy from first year. We start to talk about what's abnormal in second year. And then in third year, we start to tie it all back together. So we know what's abnormal. Now, what are the differential diagnoses? So the different possibilities that could be happening in our patients. And then fourth year, we continue to kind of wrap it all together by looking at all these different clinical cases through radiology rotations on the clinic floor. When the student veterinarian graduates and goes out into practice as a DVM, they're going to use radiology in practice. It's most veterinarians are using radiology in their day-to-day veterinary life. It's being done in most clinics. It's especially common in small animal clinics. And for the most part, in today's society, this is digital imaging. So you take digital images. It used to be film images, sort of the old school way. But now you take digital images and you either interpret those in-house yourself, and that's where the education that comes through this program comes in, or you send it out to a radiologist. And then how are these images made? Well, that's due to the magic of X-rays. And so we can thank some of the founders of radiation and specifically X-rays, Wilhelm Röntgen, which is this gentleman right here. He discovered X-rays, and this is the first X-ray taken. This is an image of his wife's hand. And this is, sort of what spurned us down the path of being able to use imaging to identify things in our patients. And so we have him and these other founding features of radiation and X-ray imaging to thank for this. And so why are we doing this? Why are we taking images? It's moved beyond just the interest of imaging our own hands, but really what we want to do is use imaging and radiography specifically in many different disease processes. So different illnesses that dogs and cats and horses and cows can have, radiographs will be used as a baseline diagnostic. It's something that we might use sort of at the beginning of when they start to present sick. Some common causes would be coughing, lameness, metastasis screening. These are really common in small animals. And then of course, vomiting, which is kind of that big thing that I want to talk about today. So we all, if you have a dog at home, probably that dog has vomited at some point. And then the question is, what do we need to do about it? Is it just a one-time thing? And for those of us that have been unlucky enough, it might be something more than that. It's something that the dog is very sick. And one of the first steps in trying to figure out why is to take X-rays or take radiographs to figure that out. And so this is what a normal dog's abdomen looks like. When we do radiography, we always do two views. We call them orthogonal projections. So at the very least, we're doing two of them. And what we would hope is that in most instances, and what I try to teach all of the student veterinarians here, is that we should be doing three views in most instances. But to start with, when we look at these two, we can think about this as having a number of different normal organs in the abdomen. So when I look at these radiographs, I want to look at all of those organs in turn to try and help me figure out what might be going on or what might be wrong. In our patients, we've got a liver, it sits here, and it sits up here. And we've got a stomach, which sits behind the liver here. We've got a spleen, and the spleen is here. It's kind of interesting shape in this little guy. This is the stomach, kind of sitting again in behind that liver. And then, of course, there's this big mishmash of stuff in the middle, and that's all the small intestinal tract, is kind of all of these loopy looking things. And then the large intestine, the colon, is this bigger one sitting up here. And again, in this projection, the colon is this big loop here. It's got this heterogeneous material in it. It has both gas, which is the dark stuff, and a combination of soft tissue and mineral, which is the more white stuff, and that's sitting in the colon. And so the other things that we can kind of see here are the kidneys sitting up dorsally. There's a couple of them, and we don't see them as well. Whoop, jumped slides. We don't see them as well in the ventrodorsal projection. So we can do a similar thing with cats, right? They have a very similar appearance and a similar anatomy, though of course they're a bit smaller, and they have a few different disease processes that we sometimes see. But these are normal radiographs of a cat, and so we can do the same kind of thing. We look, we see the liver, we see the stomach, we see the liver and the stomach. We've got a kidney here, we've got kidneys here. This one here is the urinary bladder. We've got all of these intestinal segments here and the colon. The colon, the intestinal segments, and the bladder. And so we're using the information in both of these projections to help us figure out, hey, is this something that's normal for us? And normal is something that we get used to over time, looking at hundreds and hundreds of these. And abnormal is something that we then start to factor into our assessment. So sometimes we're faced with a patient that has a really obvious abnormality. So I'm going to go through a number of examples. They're going to range from being incredibly obvious to not that obvious at all. And I want you to think about and talk amongst yourselves, kind of in your home there, what might be going on in these patients. So this animal has something in its stomach, right? It's something that looks like it doesn't belong. And so I pose the question to you, what do you think that is? What is this item here that's sitting in the stomach in all of these projections? It kind of has the shape and the appearance of something we might see at home, right? So if you said that that was a battery, you would be spot on. So this dog actually had the very bright idea to eat a remote control for the TV and had a battery, and we can actually see a little wire as well coming off of that in association with it. So that was this dog's bright idea. It seemed like a yummy snack. Maybe somebody had some peanut butter on their fingers while they were flipping channels. But anyway, the battery and the remote ended up in the stomach. And so what do we do about this? Well, in this patient, we were actually able to scope it out, which means we use something called endoscopy. It's a camera, goes down the esophagus into the stomach, and we use these grasping forceps to pull out the abnormal material. And this dog had a perfect full recovery, happy to go home and eat another remote control or maybe a smoke detector next time, who knows? Well, what about this one? This one looks pretty familiar too, right? And we can see it really well, similar to the battery, because it's metal. So we've got this circular structure here that's got these little, base on it there. So anyone have any ideas of what that might be? Well, if you said a ring, you're absolutely correct. So a ring is what this is. So not a great thing, and a pretty expensive thing to eat. But a fun fact about rings is that diamonds are radiolucent, so they don't appear radiographically. We can kind of see that you can see the metal here, but you can't see the actual diamond coming off of it. So if anybody's ever curious if their diamond is truly real or if they maybe got ripped off, all you have to do is feed it to the dog and go in for some x-rays. I do not, absolutely do not recommend that. I hope that the joke can come through Microsoft Teams here. So what about this one here? This one's a bit more challenging and might appear to some of us as almost normal. I'll give you a few hints. First of all, the foreign body in this patient, just like the last two, is in the stomach. So we've really got to focus here on the stomach to look for what we might be trying to find. And what kinds of things do we see in the stomach in this patient? Well, it's mostly gas. It's mostly dark black, right? But there are a few of these well-defined structures that sit in there. Like this guy here. There might be another one kind of similarly shaped, but maybe it's in a different orientation here and here. And this is where sort of seeing more and more over time can really help us figure out what's going on. So let me just clear that. I'm going to remove that so you can kind of see it again. So I hope you're thinking about what different sorts of things these can be. So thin-walled, filled with gas, Maybe we might pick them up at the sponsor of this talk at Wren's. We go, we think we're going to have a great time with our dog, but of course then the dog decides that it wants to eat a bunch of squeakers. So this dog had 4 or 5 squeakers in its stomach. It really had a propensity to eat those. So just a point that some of these foreign bodies that we see, you know, if they're not metal, maybe they are a little bit more challenging to identify for us. Well, what about this one here? This one is also pretty difficult, and you can see I actually had to manipulate the image a little bit to try and help us identify where it might be, and that was in the stomach here. It's this structure, so it's a cylinder, and this cat was actually in hospital when we thought that it had this foreign body, and we had to take these images. So it's got this cylinder in its stomach. You can hardly see it in the other projections, but what are some options of what that can be? Well, in this instance, it was actually the top of a pilling gun. And so for anybody who's tried to pill a cat, it can be one of the most challenging endeavors in the world. And, you know, this is how it should go. You kind of pop the pill in the cat, you rub its throat, and off to the races, the cat gets better. But in reality, what kind of happens is, you know, you need to put on your suit of armor. Your cat will try and attack you, so you better protect your weak spots. After surviving the initial onslaught, you toss a blanket or towel, wrap it in a burrito, and all this while it's filling with rage. At some point, your cat will begin to cast dark spells, and now your cat is likely spread its bat wings, sprung free from the burrito cocoon, and you must run for cover. So while your fur demon begins its path of destruction, load the pill into something that can shoot it fast and accurately. Lock eyes with your cat. This is the language for cat battle. And before you're engulfed in flames, fire that pill into its mouth, and then having done it once, prepare for battle the next day. And of course, this is not mine. I took this from the internet, and if you Google how to pill a cat, you'll come across wonderful comics and strips like this. So my last couple here, this is a foreign body present in this region of this dog. So this is something we might find during barbecue season. So something that dogs love to eat and really doesn't do a good job passing through the intestinal tract is, of course, a corn cob. So we can kind of tell it's a corn cob. If we look back at it, we can see these little, regions of lucency all along it. It's like the little kernels line up. And corn cobs are actually pretty common for us to find in dogs. So here's a couple other examples. This one's like really obviously a corn cob. You can even see the cylinder associated with it. You can see these individual lucent regions kind of lining up those kernels of corn. Maybe this one got chewed up a little bit more. It's kind of lacking some of its structure. Well, what about this one here? This is a dog. I bet there's a cat in the house. So this guy actually ate, of course, we can even see the shape of it. You got a little tail, a little butt, a couple little ears, little whiskers on there. But this is, of course, is a little cat toy shaped like a mouse. So we got to be careful if we've got multiple pets in the house for what sorts of things might be in there. What if you have a baby in the house? Well, of course, then, you know, there's going to be some delicious goodies that the baby drops. For any of you that, you know, have had kids or have been around kids, you might recognize this structure. It's got this wonderful little plastic part and then a softer end, maybe a little ring. And this, of course, is a pacifier. And so something else that dogs can get into. And so my final one that I want to leave you with, some really interesting ones, and I don't know how this dog ended up with so many, but I'll leave it to you here to try and figure out what this is for a minute. We've got these sort of oddly shaped structures in the stomach. They kind of look like one of those other ones we looked at. They've got gas in them, but they've also got, you know, kind of a section of peripheral increase in opacity. It almost looks like there's two pieces kind of stuck on each other. We can see some sort of looking down on them, some looking at the side of them. Oh, and this one's got what looks like a little mouth maybe associated with it. And so, of course, these are rubber duckies. And I don't know why this dog decided to eat 3 rubber duckies, but I'm going to probably say that it probably had peanut butter on it as well. And that's what happened in this guy. So all of this is to say that, you know, animals can really eat a lot of weird and wonderful things. It can be a really exciting time in veterinary radiology. And so I hope that this is kind of giving you an insight on some of the things that your student veterinarian might get to look at over the course of their career, and also some information of things to be careful of when leaving around your own dog. And that's it for me. Thank you so much.
Hello, friends and family of our topaz turtles. For this bio break, we're going to be doing a little at-home scavenger hunt. And hopefully during the pandemic, you've gotten to know your home super well and can find everything really quickly. So there's going to be a couple rules that you're going to have to follow. There's going to be 10 objects. You're going to have 30 seconds to find each object. Some sides are going to have a specific object, like an apple, but some are going to have a more broad description that you can find a variety of things. For example, something round and red. Point of the game is to get out of your seat after a long day of lectures, and knowing us topaz turtles sitting through lectures all day, you will need this. All right, so let's jump straight into it. So up first, you're going to need to find an orange shirt. Next up, we're looking for a stuffed animal. Bonus points if you can find a turtle. Up next, we're going to look for a framed picture of your favorite DVM student. Number 4, a green vegetable. Number 5, a paintbrush. Number 6, some candy. Seven, a dime. 8, a pet treat? Number 9, a blue pencil crayon or marker? And our last item for today is something fuzzy. Be a little creative with this one, guys.
Hello, my name is Rachel, and today I'm here to introduce Dr. John Lamar. John grew up in Southern Ontario and graduated from the OVC in 1986. After 2 years of mixed practice in Woodstock, Ontario, he returned to the OVC to do graduate work in pathobiology, where he earned his PhD in 1991. He undertook a 2-year postdoctoral fellowship at the University of Virginia Medical School. Then he returned to the OVC to take up a faculty position in biomedical sciences. He is passionate about teaching, research, and veterinary medicine. He spends his free time in the woods with his partner Sabrina and at least 2 dogs. If you have any questions, please continue to email them to vetmed@uoguelph.ca. Thank you in advance, Dr. Lamar, and I look forward to hearing your presentation.
Hi, thank you very much, Rachel. It's great to see, well, I don't get to see the family, but it's great to know that the families of this class that I've only gotten to know virtually is with us online, and I'm really looking forward to sharing some of the things that we talk about in class. I do actually have a connection with this class. It turns out that actually Rachel's grandfather was a family friend of mine, and the very first EKG I used in practice was a gift from him. So I have very fond memories, and that was way back in 1986, just after I graduated. So it's nice to remember that when people that I know come through the class or people whose families I know. So now I'm going to share my screen with you, and I just want to make sure that it's actually live when we do this. So just okay, I see that it's circled in red. So now I'm going to start the actual lecture that's much like those that you would see from if you were in the class. So I'm going to talk to you today about one of the areas that I teach in neurophysiology, and that is trying to make a relationship between what's going on in the nervous system and the clinical signs that we might see in a dog that has a problem, or a cat, or a horse, or any of the patients that we might look at. This is a picture of my dog, one of my many dogs over the years, Fuji, and she actually had a neurologic problem where the union or the junction between her nerves and her muscles didn't work. So I want to review, before we get into the specific details of problems, I want to do a quick review of both the anatomy and the physiology of the nervous system as a way to highlight what's going on. If we take an animal, and that's any animal including us, if we take an animal and we look at what their nervous system actually looks like, we divide it into two main divisions. There's the brain and the spinal cord. That's considered the central nervous system. And then we have the peripheral nerves that lie outside and maybe innervate an arm or a leg or anywhere else in the body, but not within the brain or the spinal cord. And that's called the peripheral nervous system. So you can see right away we regionalize or separate it into little functional regions. And that's going to be one of the things that helps us over time diagnose and figure out where a problem might be in one of our patients. If, for example, you have an animal that has a lesion in its brain or its spinal cord, it will have one type of clinical signs, whereas if it has a lesion or an injury in a peripheral nerve, it will have a completely different set of signs. There'll be some overlap, but we can clearly separate them. And as we progress as veterinarians to the clinical stage, we see that that becomes something that's important for us to look at. If we now break it down and look a little more microscopically at the things that are going on, the smallest part of the nervous system that can be considered to work or be a functional unit is actually called a neuron. This isn't unfamiliar to any of you, but it is incredible when you think of all the things that the nervous system does, that every single one of them is really the function of an individual cell and then network together with billions of others to form the functional nervous system. And really, it's even more amazing when you think that the only thing that these cells really do is conduct electrical signals. If you have neurons in your body that do different things, we actually divide them into functional groups, or since we have these neurons that are divided into that do different things, we divide them into functional groups. If it's a nerve that controls muscle and muscle movement, we consider it to be a motor neuron. If, on the other hand, we've got a nerve that detects maybe where a limb is in space or whether you've received a painful stimulus like a pinch or a prick, then that's considered to be a sensory neuron. And then there's a third type of neuron where one type of neuron is just actually talking to another, and those are called interneurons. So we have motor neurons, sensory neurons, and interneurons. Interneurons are the ones in particular that do all the things that we're most familiar with internally. They're responsible for behavior, they're responsible for thought, they're responsible for processing all this information that comes into the system through a sensory neuron and organizing that into different motor activity that leaves the nervous system via motor neurons. So they really only to do all the incredible things that go on with the nervous system, they really only do two things. They conduct electrical signals. They send a message from one place in the body to another, even if it's very short, say within the brain, or very far away from the brain all the way down to the leg. And they release chemical signals. So a neuron basically has evolved in order to basically have the ability to send an electrical signal along it, and then when the that electrical signal arrives at its termination, it releases a hormone-like molecule called a neurotransmitter. And working together, these two processes, electrical signals, chemical signals, they control absolutely everything that we do. So breaking it down a little bit further, we should have some understanding before I start to talk about different clinical cases, we should have an appreciation for how they actually do this. So the way the nervous system actually does this is it actually uses the membrane to separate an electrical charge on the surface of a nervous cell. It's actually true on every cell in your body, but it's the most pronounced and important within cells of the nervous system. And this membrane charge, this electrical signal, is called the resting potential, and it's caused by proteins that sit on the surface of every one of our neurons. And so those proteins can be things like channels or pumps or pores that basically separate a positive and a negative charge over the membrane of every neuron cell. So they're called, as I said, pumps, ion channels, and pores. So I said that they have to have an electrical signal or an electrical charge on their surface first, but the second thing that they have to do is they have to be able to move that potential along in a kind of a regulated fashion. And basically those moving potentials are called action potentials. So they're what we think of as an electrical charge, where you get a jolt of a very low voltage electrical signal that moves its way along the length of these neurons, which can be very, very long. And this is mostly due to the action of proteins that sit on the surface of the membrane that are called ion channels. All right, so if we think about ion channels and how they might be defective in some cases and cause disease, we do actually see some ion channel diseases in our patients. And this is probably the most obvious example of an animal that has an ion channel present within its actual muscle tissue, but right where it meets the nervous system. So if you watch these goats, first of all, I want to emphasize this is non-painful and they're not hurt in the process that you'll see here. Oh. So you can see the goats are perfectly normal. And then when they get startled, they have a reaction. And you can see that they basically seize up and are no longer able to control their muscles. And so this is a problem with one of those proteins that's on the surface of a nerve or a muscle cell that causes those action potentials to happen repeatedly and not be regulated. So what we get is a repeated pattern of action potentials that once it starts keeps firing. And that goat, as a result, has a continued pattern of muscle contraction because this is in one of those motor nerves. So now you can start to put together the things that I said in the background with the first clinical disease scenario that we've seen. This is called myotonia because the muscles remain very high toned when they're contracting. And it's a result of a defect in a protein that's present on the surface of these cells called ion channels. So it's an interesting example of what goes on. And the really cool thing about ion channels and diseases of ion channels is they've actually contributed to our understanding of how normal muscle actually works. So I started with the movement of an electrical signal along the length of a neuron. Now what I want to just do is go to the next step where we have the next thing that we know that a neuron does, and that's hand off a chemical signal. So a chemical signal is called a neurotransmitter. And a neurotransmitter gets released when the action potential, you can see in the diagram here, arrives at the end of the neuron. That structure is called a synapse, and there are billions and billions of synapses within the nervous system of an animal's body. And different synapses have different neurotransmitters, but certain problems of different types happen depending on what type of synapse we're talking about. And a reasonably common clinical disease that we see in dogs that's also seen in people actually is a problem with a defect in the number and activity of synapses. And so this diagram here, or this video here, shows you an example of a dog that has a problem with his synapse. Now, if I could ask you questions, I would stop it here and I would ask questions that I'll now do rhetorically. But if you look at this dog, you can say, difficult to tell what's going on there. Is this dog painful? Is it lame because it can't move its limbs properly? Does it have another problem that has nothing to do with the nervous system? What I'll tell you is that this animal is actually weak. Sorry, the video moved ahead unexpectedly. So she's weak. And you can see that she has to sit down and can't move along as quickly or as robustly as a normal pup. So this clinician here, this neurologist, she's giving her a drug now that's going to help with the activity of the synapses that this pup has left. And you'll see a remarkable change in the dog's ability to move. And once we've done that, we'll actually talk about for a second, or I'll talk about the things that might be going on that explain the molecular basis of this clinical disease that we see in the dog. And it's remarkable. So how about that? And that's strictly because the drug that the clinician gave increases the activity of the synapses in that dog. Pretty remarkable. So let's just go back to this diagram that I had a minute ago, and I'll point out to you that if we look down at the area that I've kind of highlighted in a red box here, is that the drug that she gave inhibits the activity of the enzyme that breaks down that neurotransmitter. And because it breaks down that neurotransmitter, it lives longer and the synapse works better. So what we have is an accumulation of more neurotransmitters. So the dog that didn't have enough of it before now does have enough of it and can resume its function. So that's another remarkable example of a molecular problem with a synapse that we can correct with a drug that makes things better by overcoming that problem. The next thing we have to consider, and the last kind of clinical scenario is a little bit more complex, but yet perhaps easier to understand at some levels, is really the things that can happen with the nervous system when you get an underlying anatomical problem. So this will rely more on the things that you've heard about in the two previous lectures from our anatomist and from Dr. Appleby, who's a radiologist, who talked about structural features that you could visualize on a radiograph. So if you look at this diagram again, you can see that we've got a brain and a spinal cord, and signals that control the movement of the limbs tend to run from the brain down the spinal cord and then out through those peripheral nerves. And if we look at it in a little more detail, we can see that the spinal cord, this is here just the spinal cord with no brain. On the left of your screen, you'll see that there's actually the upper segments of the spinal cord. And on the right in the diagram, you'll see that there are the lower segments of the spinal cord. And depending where along this spinal cord a problem might develop, that will present itself as very specific set of clinical signs in a dog or a cat or any patient that we're working with. So these neurons that leave, they can be incredibly long. And I want to remind you that a single one of the neurons that we might be looking at in a case of an animal with clinical disease will run all the way from the brain to the furthest reaches of the animal's limbs. In the case of a blue whale, that can be a 100-foot long neuron. And if you look in cross-section of that spinal cord, these neurons run within gray matter that's here around the inner butterfly. So you can see that there's a dark area in the middle, that's called gray matter. That's where some cells live. But there are long highways of neurons that are running in blue and red here up and down the animal's spinal cord. And sometimes we get diseases that cause a problem by interfering with those white matter highways that are present. And in doing so, they damage those neurons that are running all the way down from the brain to the most distal reaches of the foot, and they're interfering with their function. So a disc that's a problem, or trauma to the spinal cord, or a tumor leads to compression of the spinal cord, and it interferes with those electrical signals. And because Dr. Appleby flashed up some radiographs here, I know you're now all expert in it, and what we're looking at here is a close-in X-ray film, really, of an animal that has a problem with its disc right here. So these are normal or relatively normal vertebrae. This is the spinal cord that's running just above those individual bony structures. And you can see that where the arrow is highlighted, it's actually pinched. And what we get as a result of that pinching is a clinical scenario that looks like this.
Come here, monkey. Good girl. That's a good girl. Oh, look at you standing up. Come on, show everyone how you're walking. Come on.
So you can see that monkey's legs don't work properly. She can't feel where they are, so she doesn't know to move them. And even if she could feel them, she doesn't have the strength and the ability to move those with her muscles. Interestingly,
Come on, monkey.
this can recover after you do. So after you do a surgical correction. So you can see that monkey's improvement is fairly substantial in that she's now able to move her legs better. So monkey's had a surgical correction of a disc disease that I showed you on the x-ray. And the result is that she's actually able to move those legs a little bit better once some of the swelling around her spinal cord was resolved, and once the spinal cord started to heal.
Come here.
Now, we can't grow new neurons, but we can have the ones that were there and survived the injury. They can start to work better. So you can see that monkey is actually able to move those legs, whereas 8 days ago, she wasn't able to. So if we look in her case, what we had was damage to these motor tracts and sensory tracts that moved the signals up and down her spinal cord. So she couldn't tell where her legs were, and she couldn't send a signal to move them properly. But over time, those things started to recover. So basically, to summarize, those are 3 case examples and a little bit of background to go with them that give you a sense of how important the nervous system is and how complicated it is, and the amount of work that your loved ones have to do in order to memorize all this so that when they see patients like this, they actually understand what's going on and can do something about it. So with that, I want to remind you that neurology is really universal, and all physiology is, and I want to thank the class of OVC 2024 for this amazing opportunity to speak to your families and loved ones. And I hope you enjoy the rest of the show, and it's been an honor speaking to you today.
Hello, everyone. My name is Elise, and today I have the pleasure of introducing Dr. Peregrine, who is here to speak to you today about some interesting parasitology cases. Andrew Peregrine graduated from the University of Glasgow Veterinary School in Scotland. He then received a PhD from the same university for work on parasitic diseases of cattle in Africa. From 1987 to 1997, he worked at the International Laboratory for Research on Animal Diseases in Kenya, carrying out research to improve control of tropical parasites in cattle. Since 1997, he has been on faculty in the Department of Pathobiology at OVC, where he teaches clinical parasitology to DVM students. In addition, he regularly provides advice to small and large animal practitioners on how to manage parasite problems. Outside classes, he plays squash, tries to play hockey, and is currently busy at home with Gus, a poodle and Wheaten Terrier puppy. If anyone has any questions today for Dr. Peregrine about the presentation, you can email them to vetmed@uoguelph.ca. Now, without further ado, please give a warm welcome to Dr. Peregrine.
Elise, thanks very much. And hi, everyone. I hope you've had a really good day learning a little bit about OVC and what all your fellow friends are doing here. Let me just give you a picture of myself so that you know who's speaking to you. And on the right, Elise mentioned actually I worked in Kenya for 12 years before I came here. And there's actually a blood smear from the cow that I was working on the whole time I was in East Africa. And the disease it causes is shown in the cow in the bottom. It's an incredibly important disease of cattle right across sub-Saharan Africa. The parasites are called trypanosomes, and they're transmitted by tsetse flies. So Elise mentioned I'm a veterinary parasitologist, and I actually teach, not actually in first year, we haven't met yet, unfortunately, but I teach in second year and particularly third and fourth year of the DVM program. In second year, what all the first years will be learning is how to recognize all the important parasites of all the domestic animal species. And then in third and fourth year, we talk about treatment of infection and what to do to prevent animals from getting infected. So what I was asked to do today was to tell you about some of the most fascinating cases I've seen, and I'm going to do that. Hopefully it gives you some idea of the breadth of cases that as vets we're asked to look after. I should warn you, some of the images you might find a little disconcerting, so if you're a little bit queasy, please hang on. I'll be finished in 20 minutes if you can hang on that long. And the other warning is to give you, there's a final exam at the end of this, 3 questions, so get ready to answer those. So let's move on to dogs. What are some of the fascinating cases that I've seen in dogs? This is actually a picture of Rosie. Rosie is a Labrador Retriever mix that some years ago was picked up as a stray in the Thames River area in southern Ontario. That was in the summer that she was picked up, and then an owner took her into their house. But the following winter, one day, whilst Rosie was being taken for a walk in the snow, they noticed her urine was extremely red, and so they took her immediately to their veterinarian, who collected some urine from Rosie and put it under a microscope. And this is actually a picture of Rosie's urine under a microscope. These are extremely unusual structures that we occasionally see in the urine of dogs in southern Ontario. These are eggs of a very extraordinary parasite called the giant kidney worm of dogs, or Dioctophyme rhinale. Now, we knew she was passing eggs in her urine, but before the infection was managed, it was important to find out how extensive it was. And so the vet carried out ultrasound examination of the entire abdomen of Rosie. And this is actually a picture of Rosie's right kidney, right? Extremely unusual in appearance. You can see multiple spherical structures, which are actually cross sections of this parasite. And you can even see what looks like a longitudinal section or a sausage structure, which is part of a parasite as well. So they knew the right kidney was significantly involved. The left kidney looked fine, which was great because it meant her right kidney could be removed and she would live quite happily on her left kidney. They also found out there was one large parasite living free in her abdomen. And so she was taken for surgery to do what's called an exploratory laparotomy. So they opened up her abdomen or her tummy and started looking for these parasites. And this is what they found lying free and moving in her abdomen. This is just one parasite. It's about 3/4 of a meter in length and about 1 centimeter in width. And this is the giant kidney worm, or Dioctophyme renale. You do sometimes find them free in her abdomen. So that was found moving around her abdomen, but they also knew the right kidney was significantly involved, and it was decided it had to be removed. After the kidney was removed, the vet opened the kidney, all right, and this is what came out of it. In fact, 3 additional parasites living quite happily in the kidney of Rosie. And you probably appreciate, if you've ever seen a kidney, there's almost no normal kidney left, which is why there was no normal kidney left, which is why the surgeons decided they had to remove the entire kidney. The dog subsequently recovered extremely well from that surgery, and to this day she's actually owned by someone that lives in Guelph. You probably don't know, but you are lucky enough to live in what's called the land of the giant kidney worm. There's very few places across North America that have this particular parasite. But one of the obvious questions is, well, how did Rosie get it? And it's extremely important to know how animals get infected, because then you can prevent other animals from getting infected. Rosie got infected in the Thames River area of southern Ontario because in that location in southern Ontario, this parasite is a common infection of mink, and it's actually a wildlife-associated parasite. It lives in the kidneys of mink, all right, and they then pass the eggs into the environment in their urine. If those eggs pass into water, so the Thames River, those eggs hatch, a tiny little baby worm hatches out of that, and then it burrows in to worms that live on the edge of the river. They're mudworms. And in fact, this little red speckly appearance is supposed to represent a parasite lying inside the worm. So one of the ways minks get infected is by eating infected worms. But there's another way that's probably much more common. And it's associated with the fact that if either frogs or fish eat these infected worms, the parasite passes across into their muscle tissue. It doesn't make them sick, but if they're eaten by a mink, that's how the mink gets infected. So it shouldn't be too surprising to know Rosie most likely got infected by eating fish or frogs on the edge of the Thames River. Now, as I said, it's an unusual infection, and it always has been an unusual infection until the last few years. And in just the last few years, we've been working with a number of vets who've been working in northwestern Ontario, where it turns out it's an extremely common infection. For instance, in the Sandy Lake First Nations area, up to 30% of dogs are infected with this. And so a number of us are working with vets trying to help dogs in that area with this particular infection. If you ever go and work in the Thunder Bay area, they see it occasionally. And I thought I'd show you a picture that Dr. Smith sent me from one of the Thunder Bay clinics. This parasite is actually almost a meter in length, found in the abdomen of a dog in that area. So that's the giant kidney worm, Dioctophyme renale. What's another interesting case I've seen in dogs? A few years ago, a vet phoned me up and said, can I show you a picture, send you a picture of a dog with something strange extruding from the lower part of the limb. And so this is a picture of the limb of the dog, and there's this white structure that's extruding out of that location in the skin. And the vet said to me, do you think that could be a parasite? And I said, well, there is one parasite. We very occasionally will do this. All right. And to confirm that it is this parasite, you need to collect fluid or associated with where what looks like a parasite is extruding from the skin. So the vet stuck a needle into the skin, and then with the fluid that was collected, it was put on a microscope slide and stained. All right. And these are all cells on this slide, except this very obvious looking parasite or a larval structure with a very obvious pointed tail. And this confirmed that what we were seeing is a parasite that's called Dracunculus insignis. It's extremely closely related to the guinea worm that infects people across Africa. And so what's happening in this picture? This is actually an adult parasite. It's an adult female parasite, and we only ever see them in the lower parts of the limbs. And because the reason they're extruding the rear end of themselves, and this is the rear end of a female parasite, she's laying these larvae into the environment, and they only survive if this happens in a water environment. And so that's why we only see these parasites in the lower parts of the limbs of dogs. So those pass into water, they then infect copepods or crustaceans in the water, and the dog gets infected by ingesting those in the water. Now, the next question vets always have, because almost no one's seen it, is how do we manage it? And how do we manage it is based exactly on how infections in people are managed in Africa. This is a person with one of these parasites in the tissues in their foot. Again, the female parasite is extruding her rear end. And the way this is managed, they're very long parasites, and you typically can't pull them out completely, and you do not want to break them. And so what we do with these infections, you literally wind them up on a toothpick or a cocktail stick. So you wind them up, and then you put a bandage over it or elastoplast, and then the next day you wind it a little bit more. So slowly, after multiple days, you pull the entire parasite out. And that's exactly what we do with dogs. So it's interesting. We've actually learned how to manage this from a very similar infection of people in Africa. So that's trachunculus infections of dog, also known as the guinea worm in Africa. So what about those of you that are interested in horses? What interesting cases have we seen in horses? Well, before I tell you about one of the most interesting, you need to just appreciate a technique that's often done, and it's called nasogastric intubation. And for this technique, a tube is literally inserted up the nasal passages, down the esophagus, into the stomach. And the clinicians will do this sometimes for certain cases because they want to remove fluid from the stomach or wash out the stomach if there's any concerns about something that shouldn't be in the stomach. This actually shows you a vet that stuck one of these tubes down. Once it's in the stomach, typically water will be flushed down the tube into the stomach, all right? And then the tube will be put into a bucket on the floor. And usually just very bland looking fluid comes out. Until one day, a vet phoned me up and said, I've just done a nasogastric intubation on a foal, and this is what we saw in the fluid in the bucket. I would ask you, is there anything abnormal you can see in the fluid that's come out of the stomach of this horse? It's not a snake. It's about a foot long. It's about 30 centimeters in length and white in appearance. This is actually the roundworm of foals, also known as Parascaris equorum. It should be in the small intestine. That's where roundworms live in all species. The fact that it's in the stomach is very suggestive there's a large burden. That's an unusual presentation, but we are also seeing some other very unusual presentations. A few years ago, I got phoned up by another equine vet in Southern Ontario. This was a 9-month-old foal that was rushed into a clinic with severe abdominal pain or colic, all right? And just looking at the rear end of it, you can see this structure extruding from the anus of this horse. This is actually a roundworm. And as I said, they should be in the small intestine. When you see them in the stomach or you see them coming out of the rear end of the horse, it's very indicative there's a large burden in the small intestine. But this whole foal had been dewormed as you should every month since birth. So this was very odd. The horse was rushed into surgery, and the surgeons immediately noticed there was actually something blocking. This is the small intestine that the surgeons have opened to reveal what's called a roundworm impaction. Massive numbers of roundworms that have impacted. Why are there massive numbers despite deworming? Well, just recently we've appreciated these parasites have developed significant resistance to some of the common dewormers we use in horses. So unfortunately, we're seeing this quite a lot these days. Now, those are the 3 obvious cases. Every now and again, I get phoned up by a vet that says, I'm looking at something and I have no idea what this is. Can you please help? I don't even know if it's a parasite. One of the most interesting phone calls I've ever had was from a vet in Dryden, way up here in northwestern Ontario, phoned me up in June of 2016. He was actually standing in a field containing many horses, and he said, I'm looking at something in the grass, and I don't know if it's a parasite of horses, whether I should be frightened or whether there's something it can do to these horses. So I said, is there any chance you can send me some pictures or a video? And this is actually a video of what he sent, looking deep into the grass. Hopefully you can see this long wire-like structure. It's about 25 to 30 centimeters in length, all right? Whitish brown to black in appearance, and it's moving around in the grass. just in case you can't see that in the video, this is a very similar one, all right? This long, what looks just like a parasite, and actually it is a parasite, all right? It's in the environment, moving around, and we typically see this in the morning during the summer months. And this is called a horsehair worm or a Gordian worm. Is this a parasite of horses? No, but what's it doing there? Because there's some important things to appreciate. It's moving around in the morning trying to locate blades of grass, because once it finds blades of grass, it deposits its eggs on the blades of grass. Now, these are not a threat to horses, but if any insect ingests this, it can cause very nasty disease in insects. Now, you might be saying, so what does this have to do with veterinary medicine? Well, it might not be horses that are a concern, but just a year or two after I dealt with this case and said you don't need to be frightened of those, the horses don't need to be concerned, and it's certainly not an infection of people, I got a phone call from Toronto Zoo. And the Toronto Zoo said, could you please have a look at our grasshoppers? And I said, I can. Can you send me some pictures? And they said, yeah, just in the last week, we've had a massive die out of our grasshopper colony. And every single one of the grasshoppers, when you open them up, are full of these long white parasites. And the first question, what are these? And I said, these are Gordian worms. And then they said, well, then how did the grasshoppers get infected? And I said, you must have provided something that they fed on that contained eggs of this parasite. I showed you those on a blade of grass before. And lo and behold, just a week or two before they started dying, they provided their entire grasshopper colony, all right, with some raspberry bushes. And when they looked closely on those raspberry bushes, they could see lots of the eggs of this parasite. Now, grasshopper is an extremely important thing for Toronto Zoo because there's many species, such as lizards and snakes, that feed on these. And so this was having a massive impact on the nutrition of multiple species at the zoo. So you never know what you're going to get involved with. What happens if you just leave these infections alone? All right, well, these are these Gordian worms developing from ingested eggs in the hemoslomic cavity of these grasshoppers. You may be lucky eventually to see they actually break out of the surface of these insects into the environment. And so if you ever see this, that's what's happening. It's one of these parasites breaking out into the environment. This is actually a picture of a beetle that had one developing inside. You can see it's massive coming out into the environment. So veterinary medicine is extremely odd and diverse. And the last case I thought I'd show you is those of you that like cats. And folks, I hope you're all still with me and that no one's passed out. But I should warn you, there are some pictures for this one that some of you may find disconcerting. This is a cat that a vet phoned me up about and sent me a whole bunch of pictures. She said the cat's just been brought in, and the owner brought it in because they're concerned there's just a black deposit on the external nares. But if you look inside, you can see multiple black dots on a structure. And if you look on the front of the nose, it's actually broken and this similar structure is coming through. And so the vet literally got hold of that and pulled it slowly. And this is what came out. It's what's called Cuterebra. It's an insect larva, and those of us living in southern Ontario may not appreciate, we're one of the few places across North America where this is a common infection, and we see it every now and again. It's a wildlife infection, but every now and again we see it in dogs and cats. All right, it's associated with a fly that lays its eggs around rodent holes. Right, and if a cat or a dog sticks its head down the rodent hole, the eggs hatch, crawl onto their skin, and then ingest it. They then migrate typically through to the skin, which is where we usually see this. This one happens just to be associated with the nasal cavity. It's a fly larva or a maggot, right? And it's come to the skin because for the final stages of development, it needs oxygen and it eventually drops off into the environment. But that case is extremely unusual. That was what was left in the cat, and the vet did some reconstructive surgery afterwards. So it's a very odd presentation. Usually we find it behind the head, somewhere under the skin, and a little hole appears, and you can actually see it moving around under the skin before it breaks out into the environment. Now, for many of the parasites we deal with, People often ask me, well, that's infecting my cat or my dog. Could it infect us? And the answer for Cuterebra is it can. And over the years, I've been involved in a number of cases or helped a number of human cases at the hospitals in Toronto. And I thought I'd show you some pictures of a child that was diagnosed with a Cuterebra infection. This child had presented to a physician. All right, this is looking into its eye, and the conjunctiva, you can see a swelling in the eye. And it was then, child was taken for surgery, all right, and so they've made an incision into this tissue, and that's slowly pulling out what you can see at the bottom is actually a very characteristic Cuterebra larva. It's much less common in people than it is in animals, but it is an infection. And so it's funny, as vets, we're often more likely to be able to diagnose this than our human counterparts. We just deal with parasite infections in North America much more commonly than our human counterparts. So folks, I hope that was some interesting cases. I've got 3 final exam questions for you. First one, this parasite was found at post-mortem in the thorax of a dog. I haven't mentioned this one, but I thought I'd see if you can answer it. So found at post-mortem in the thorax of a dog. The parasites shown, are they heartworms, hookworms, roundworms, or whipworms? Hopefully you can appreciate this is actually the heart of a dog and a massive burden of heartworms inside. So the correct answer is heartworms. Question 2. These were all found in the abdomen of a dog. Are these parasites whipworms, roundworms, hookworms, or giant kidney worms? That's right, they're all giant kidney worms, which is an odd name for finding in the abdomen, but almost certainly there would have been parasites in one of the kidneys of this dog. And lastly, this was removed from the axilla or the armpit of a cat. All right, so this is the axilla of the cat. You can see this large skin lesion here where this structure was pulled out of. All right, it's about 1.5 centimeters in length. Is this parasite a Cuterebra, Gasterophilus, Hypoderma, or Estrus? Hopefully you appreciate it's Cuterebra, the insect larva I've mentioned. The other parasites are all other insect larvas. The second one we find in horses, the third one we find in cows, and the fourth one we find in sheep. So folks, I hope that was useful, and I hope that got you fired up for moving on to 2nd, 3rd, and 4th years of the DVM program. Folks, thanks for listening to me. Hopefully you're all still conscious. Thanks, folks.
All right, thank you everybody for sticking with us for the rest of the day. I know it's a lot to sit in front of a computer for 6 hours, so we appreciate that you stay here and made this a priority. It took a lot of hands to make this day happen. So my name is Aaron. I'm one of the vice presidents of the Topaz Turtles. I had the pleasure of working with the fundraising team and our sponsors to organize funding for the event today. So I'm just here to send a huge thank you to our sponsors. Without your help, this day would not have happened, and future events like our graduation wouldn't have been possible either. So we're so grateful for that, and on behalf of myself, Michelle, who you're going to hear from in a minute, and the remainder of the Turtles, we just want to send a huge thank you for all of your help today. And also just wanted to send a shout out to Amy Tremaine and Adriana Tremontoa and the Advancement Office for helping coordinate some of the funding that we received from some of our sponsors. So thank you to you guys, and I'll pass it off now to Michelle to finish up with the auctions.
Hi everyone, my name is Michelle and I'm the other co-vice president of the class of 2024. So I'm just here now to remind you to go and check out our auction, which will be closing at 4 o'clock. So myself, Aaron, and our sponsorship team have worked very hard to procure all of these very interesting items, some of which might be tickets to see events, others are physical items or gift cards. So if you haven't already, please go and check it out. And if you are bidding, it will be closing soon, so make sure that you double check to make sure that you're still the winning bid. And if not, keep on going, let the bidding wars ensue. Thank you so much, everyone, for joining us today.
Hi, everyone. Melissa Mazzotti here, Topaz Turtle co-president. I hope you enjoyed our virtual Family and Friends Day. A special thank you, of course, to the wonderful friends and family that are here today participating, donating, and soon repping your own turtle merch. We could not be here without your continued support today and every day.
A big thank you to all of our professors for being here, as well as our Manager of Student Affairs, Elizabeth Lowinger, Dean Witchell, Associate Dean Joanne Hewson, Dr. Paul Wirtz, our Alumni Association rep, our wonderful tech team, Scott Moshe, who has helped us create the wonderful websites you're using today, as well as Kevin Hogg for running this entire live event. We have had a big Turtle team working behind the scenes to ensure this virtual event was a success. So thank you so much to every Turtle who has volunteered their time today. We are so glad we got to share with you a day in the life of a student vet virtual edition. We really hope that you've enjoyed your day and maybe even learned a thing or two. Hopefully we'll be able to bring you onto campus soon in order to give you a complete full experience. And now I am happy to announce the winner of the bingo card. Thank you to everyone who played. We're so happy you all enjoyed this activity. The winner of our free Topaz Turtle mug and lanyard is Mr. Kevin Lucas. And because we had so many people play, we wanted to give our second place winner, Miss Julie O'Neill, a free turtle mug and lanyard as well. Please have your student turtle representative get into contact with me so we can get you your prizes. And thank you everyone again for playing. So a final thank you for being here today. We know that you stuck through it and we're patient with a lot of our technical difficulties, but we hope that you enjoyed your day and have a wonderful rest of your weekend. Take care, everyone.